Good afternoon, everyone. Hopefully, I'm audible and the screen is visible too. If the audio visuals are fine, please let me know in the chat box so we can proceed. Great. Chalo. Let's start. Next one will be pancreatico-hepatobiliary system. So now first is pancreas. Important question. If they ask you which is the most common congenital anomaly or congenital defect in the pancreas beta, then your answer has to be pancreas divisum. We know that pancreas are usually formed by two buds beta, the dorsal and the ventral pancreatic bud. And when the dorsal and the ventral pancreatic bud are not going to fuse with each other beta, that condition is known as pancreas divisum, which is the most common congenital anomaly. A lot of people tend to mark it as annular pancreas. No, annular pancreas is not the most common congenital anomaly to be remembered. Okay? So it is pancreas divisum. Next important here, if they ask you a question which states beta, a male patient presents to the emergency room with sudden onset severe acute epigastric pain. That pain radiates to the back of the patient beta, and this pain worsens whenever the patient lies supine, and this pain is relieved whenever the patient bends forwards beta, along with nausea, vomiting, fever like symptoms. What is the next best step? So first of all, the provisional diagnosis of this case has to be acute pancreatitis. Now we know whenever they say beta that there is a severe epigastric pain radiating to the back, it has to be likely to be a case of acute pancreatitis. Reason is pancreas is a retroperitoneal organ beta. Therefore, the patient's epigastric pain immediately radiates to the back. Okay. Important is as the patient lies down supine beta, all the abdominal organs fall on the inflamed pancreas, and that causes worsening of the pain. So in supine position, the pain worsens. But when the patient sits and bends forwards beta, okay, the pressure on the pancreas is relieved, and therefore the patient feels better. Like the pain of the patient is relieved when the patient sits and bends forwards. Okay? This is the likely diagnosis of acute pancreatitis. Important is, do remember, if they ask you chest pain which radiates to the back or to the interscapular area, what is the thing that will come to your mind? A recent NEET PG question, when they say chest pain radiating to the exact center of the back beta or the interscapular area. I know that chest pain radiating to back slightly on the left side, left arm, left shoulder, and left jaw is MI, myocardial infarction. But if they say chest pain exactly radiating to the center of the back or the interscapular area, what is the likely diagnosis? Please let me know in the chat box. Then it would be a case of aortic dissection beta. That means tear in the aortic wall, right? That condition is known as aortic dissection. So if they say chest pain radiating to the interscapular area of the back exactly in the center, it is a case of aortic dissection. Yeah. Now if I come back to aortic acute pancreatitis beta, we know in acute pancreatitis the most cause is gallstones. Why? The gallstones will come beta and they may block the opening of the main pancreatic duct. Why? We know because the common bile duct and the main pancreatic duct open together at the ampulla of Vater, which is present in the second part of duodenum. Therefore, when there is a gallstone, it may come and block the main pancreatic duct, and that leads to collection of secretions inside the pancreas, which may cause inflammation beta, and that is acute pancreatitis. So most common cause of acute pancreatitis is gallstones followed by alcohol beta. Okay? Important is if they ask you when a patient of acute pancreatitis comes to you, please remember the most sensitive, the most specific test, the investigation of choice, okay, the gold standard test overall, it has to be nothing else but beta, but serum lipase or serum amylase. Okay? So please remember the gold standard investigation of choice, whatever they say, the best test has to be serum lipase beta followed by serum amylase. Why serum lipase would be the best one? Reason serum lipase is specific to the pancreas, whereas amylase can also be found in the saliva, so it is non-specific. So if you have to choose one among them, answer has to be lipase. Okay. Next important is beta, if they ask you radiological investigation of choice. So radiological investigation of choice in a case of acute pancreatitis has to be a CECT abdomen. I've told you rather that the best radiological investigation for all retroperitoneal problems has to be a CECT abdomen itself, except one condition, and that is Wilms tumor beta. Okay? Except in Wilms tumor. When Wilms tumor, the investigation of choice is MRI. Otherwise, all the retroperitoneal problems you can mark it as CECT abdomen. Clear? Now, here, based on the signs and symptoms of the patient beta, will I be able to tell the severity of pancreatitis? Yes. So based on signs and symptoms of pancreatitis, if I am able to tell that whether it is a mild, moderate or a severe pancreatitis beta, It is done with the help of a score or a criteria called as the Ranson score. So based important question. So based on the Ranson score, beta, I can definitely tell whether my patient is having a mild, moderate, or a severe pancreatitis. Second, based on the radiological findings, beta, based on the CT findings, will I be able to tell that whether my patient has a mild, moderate, or severe pancreatitis? Yes. So severity of acute pancreatitis can be assessed with the help of a CT severity index, and that is called as Balthazar grade, beta. Okay, so that CT severity index is known as the Balthazar grade. Please remember that. Okay. I can also go for X-ray abdo, beta. When we go for X-ray abdo, and some patients of acute pancreatitis, you may be able to see this classical sign also, beta, called as a colon cutoff sign. Okay, due to the inflamed pancreas, here you are able to see a classical colon cutoff sign also. Now here the picture which is given besides this X-ray is a CT scan, beta, and on the CCT you are able to see the arrow which is there, beta, that is marking towards the inflamed pancreas, and the star which is there, that star is actually showing you the blood which is collected around the pancreas, beta. Yes, so this is a case of a acute hemorrhagic pancreatitis, beta, and when the patient may develop acute hemorrhagic pancreatitis, there will be blood inside the peritoneal cavity called as hemoperitoneum. And in patients of hemoperitoneum, beta, we'll be able to see this classical sign. First, there is bruising around the umbilicus, beta, and when there is bruising around the umbilicus, it is classically called as the Cullen sign. And second, there is bruising in the flanks, beta. So when do we see the flanks? When we turn. So please remember, if there is bruising in flanks, that is classically called as the Gray Turner sign, beta. No, you just have to remember the name, beta. The names are enough for your examination. Even in NEET PG, they do not ask gradings and details. So please remember, beta, Cullen sign is bruising around umbilicus and Gray Turner sign is bruising in the flanks. Can anybody tell me these clinical signs of hemoperitoneum will also be seen in which condition of obstetrics, beta? OBG में कहाँ पढ़ा है? Please let me know in the chat box. Important is if they ask you management, beta, do remember that management is usually conservative management. Yes, keep your patient NPO, IV fluids, IV antibiotics, and analgesics, beta. We do not need any surgical management in patients of acute pancreatitis. Okay, so that has to be remembered. Initially, the patient will be NPO for the first 48 to 72 hours, beta, and as early as possible, we will try to come back to enteral nutrition. So yes, in the first 48 to 72 hours, we'll keep the patient on IV fluids, but after 48 to 72 hours, as early as possible, bring back the patient on enteral nutrition. And in enteral nutrition, it is usually the nasojejunal feeding that we do. Okay, nasojejunal tube we insert. Next important is if I talk about the chronic pancreatitis first. In cases of chronic pancreatitis, beta, here the patient will come to you with a long history, also almost months, 3 months, 5 months, 6 months history, beta, of abdominal pain. But apart from that, the patient may also have other features like the symptoms of malabsorption can be there. Okay, I'll talk about that. Please remember first thing that chronic pancreatitis ka most common cause is alcohol. Acute में it was gallstones, and chronic pancreatitis it is alcohol. The etiological classification of chronic pancreatitis is known as TIGAR-O classification, beta. Do remember this? Okay, so TIGAR-O is the etiological classification which will tell you about the causes of chronic pancreatitis. E for toxins, the most common toxin being alcohol. I for idiopathic, G for genetics, A for autoimmune, R for recurrent, and O for obstructive, beta. So these definitely are the conditions which can lead to acute chronic pancreatitis in the patient. And chronic pancreatitis, beta, the patient will have, see, as there is chronic inflammation of the pancreas will be damaged, and due to that, definitely the pancreas is going to lose their function, beta. There are two functions of the pancreas, exocrine and endocrine. Exocrine function means production of the pancreatic enzymes which are responsible for digestion and absorption of food. So exocrine function, if it is lost, there will be deficiency of pancreatic enzymes, beta, and as the pancreatic enzymes like lipase and amylase will be less. As lipase is less, the patient will not be able to absorb fat, beta, and as amylase is less, the patient will not be able to absorb carbohydrates. As there is fat malabsorption, beta, the patient is going to have definitely. As there is fat malabsorption, beta, the patient is going to have fat forming, foul smelling, bulky, greasy stools, beta. Please tell me in the chat box, what is this fat forming, bulky, foul smelling, greasy stools called as? This was a previous year question. That is a feature of fat malabsorption. Very good. Yes. The signs of hemoperitoneum are seen in patients of ruptured ectopic pregnancy. Right. ये बताओ अभी. Very good. Steatorrhea. Shabash. This was a PYQ, beta. So do remember that fat malabsorption may lead to steatorrhea in the patient. And as there will be carbohydrate malabsorption, beta, there will be a lot of gas which will be formed that will cause bloating or flatulence in the patient. Apart from that, patient may also have diarrhea. Endocrine dysfunction की अगर मैं बात करूं बेटा, we know there will be deficiency of insulin if the pancreas are damaged, and that's the reason the patient will have hyperglycemia or diabetes mellitus may develop. ठीक है. Now if they ask you investigation of choice in a case of chronic pancreatitis, now chronic pancreatitis can be due to two reasons beta. Either there is some problem in the duct, or second there is some problem in the tissue of the pancreas. If the problem is usually located in the duct beta, then the investigation of choice should be MRCP बच्चे, magnetic resonance cholangiopancreatography, MRCP. ठीक है. Whereas if the problem is in the tissue, that means MRCP appears to be normal, then you can go for CECT beta. That is nothing else but contrast enhanced CT scan of abdomen. Now, whether I do a MRCP or a CECT beta, I'll be able to see a very classical appearance. Two important appearances. First, there will be dilatation of the duct, and second, due to stasis of the secretions beta, there is formation of stones inside the main pancreatic duct. Can you see these whitish ones? So these are nothing else but the stones formed inside the main pancreatic duct beta, and this will give us a very classical appearance on the CECT or MRCP at times, and that is called as a chain of lake appearance. So in patients of chronic pancreatitis beta, there is a classical chain of lake appearance which is seen. Okay? Now if they ask you about the treatment, so first line management is, as there is deficiency of enzymes, we should give the enzyme supplementation from outside beta, so that absorption takes place. So definitely enzyme supplementation should be given. And second, as there is deficiency of insulin, either I should give insulin to the patient, or some oral hypoglycemic agents like metformin vagara should be given to the patient for controlling the diabetes. Okay? Now, if they ask you about definitive management beta, so do remember, definitive management depends whether the problem is inside the pancreatic duct or the pancreatic tissue. If the problem is inside the pancreatic duct, we will go for draining surgeries beta. Whereas if the problem is inside the pancreatic tissue, we will go for a resective surgery. Now, if I talk about the draining surgery, which is, if I talk about the draining surgery now, if the duct is less than equal to 6 mm dilated beta, if the duct will be less than equal to 6 mm dilated, क्या करोगे? You will go via ERCP beta. What is ERCP? Endoscopic retrograde cholangiopancreatography. So you will go via ERCP beta, and when you go to the second part of the duodenum, okay, where we have the main pancreatic duct, we will actually make cuts or incisions on the sphincter of the main pancreatic duct beta, so that this main pancreatic duct is able to open up properly and it is able to drain all its secretions. Okay, so that is important. So ERCP with sphincterotomy is done if the duct is less than equal to 6 mm dilated. If the duct is more than 6 mm dilated beta, then I have two options with me. If the duct is more than 6 mm dilated, then we can drain the duct directly into the jejunum of the patient. How? I will connect the jejunum end to end beta. This is the pancreatic duct, this is the jejunum. I am doing a end-to-end anastomosis, or I can go for a side-to-side anastomosis. If I do a end-to-end anastomosis of the main pancreatic duct and the jejunum beta, this is called as a end-to-end pancreatico-jejunostomy, also known as the Duval's procedure beta. Our second option is when I do a side-to-side anastomosis. This is called as a side-to-side or a longitudinal pancreatico-jejunostomy, also known as the Pasteur's procedure beta. Yeah. That is important to be remembered. Now, if they say the problem is inside the pancreatic tissue, then we have to go for a resective surgery beta. Resective surgery may do remember, if there is necrosis in the head of pancreas, so I should remove the all the necrosed part beta, the pancreatic head. But at the same time, I should preserve the duodenum. I should not damage the duodenum. So this duodenum preserving pancreatic head resection is known as the Bejer's procedure beta. Okay, it is known as the Bejer's surgery. Next important, if they say there is some problem or necrosis in the tail of pancreas, in that condition I have to remove the tail and the distal body of the pancreas, called as distal pancreatectomy beta. Yeah, hopefully this is clear to all of you now. Okay, now coming back to this question, which is a complication of acute or sometimes even chronic pancreatitis. Answer this question out here beta, and then we'll talk about pancreatic cancer, and then we'll move forward. Answer this question out here. A chronic alcoholic patient presents with epigastric pain, fullness, nausea and vomiting since last 2 months. He gives history of flatulence and foul smelling bulky greasy stools. RBS is 250 milligrams per deciliter. RBS is random blood sugar. And CT abdomen reveals following finding. Which among the following is the next best step? Okay, following finding is nothing else but beta. There is a CCT abdomen. It is not printed over here. So it is a CCT abdomen on which just beside the pancreas you are able to see a black color sac which contains fluid in it. What is the provisional diagnosis of this condition, and then ABCD, what is the management? See, important is the patient is giving some history. What is the history? Flatulence and foul smelling, bulky, greasy stools. We know flatulence or this steatorrhea is due to malabsorption. That is a feature of chronic pancreatitis. Second, RBS is 250. Again, diabetes mellitus. So it is also a case of chronic pancreatitis. Now, in a patient of chronic pancreatitis, since the last 2 months, the patient is complaining of epigastric pain, fullness, nausea, and vomiting. Beta. Okay, these are pressure symptoms. Like what happens usually is very good. What happens usually is due to inflammation after acute pancreatitis or chronic pancreatitis, there is collection of fluid beta around the pancreas. Okay, so there is formation of a granulation tissue which forms a sac-like structure, and in that there is collection of fluid beta. Okay, and this condition is called as a pancreatic pseudocyst. Why we call it pseudocyst? Because that sac is not lined by epithelium, it is sacked by granulation tissue, so it is a pseudocyst beta. Okay, so this is a case of pancreatic pseudocyst. We know that pancreatic pseudocyst is a common complication, and most of them are going to be smaller in size. Most of them are going to resolve within a span of 6 weeks beta, and most of them are going to be asymptomatic. They will not cause any symptoms. But in case beta, the pancreatic pseudocyst is bigger in size definitely. So do remember, if it is bigger in size, it may start causing compression beta. It may start causing compression of the stomach, and that may cause epigastric pain, fullness, nausea, vomiting like features. Okay, so these are called as pressure symptoms if it is big in size. Or if the pancreatic pseudocyst is going to stay for 6 weeks or more beta, then we may need a management. So please remember, pancreatic pseudocyst does not require any management usually, because majority of them are going to resolve on its own within a span of 6 weeks. But if that pancreatic pseudocyst is very big in size, it causes pressure symptoms. Or if it is lasting for 6 weeks or more, definitely in that condition we need a surgical intervention for the pancreatic pseudocyst beta in these two conditions. Clear? Now what should be the treatment over here? We know we can drain the cyst beta, and for drainage of cyst there are two options, either an internal or an external drainage. External drainage is the ultrasound guided pigtail catheter insertion. Yes, under ultrasound guidance you can insert a pigtail catheter, and with the help of that you can drain the cyst completely. Another option is an internal drainage beta, and in internal drainage what we do, we open up that cyst into the stomach. That will be called a cystogastrostomy, or I can open up the cyst into the intestine beta, called as cystoenterostomy, right? And cystoenterostomy ka hi type is nothing else but cystojejunostomy, right? So please remember beta, you can do an internal drainage for the pseudocyst, and that is done by option C. Cystojejunostomy has to be your answer. Clear? Observation and follow-up would have been done in a pancreatic pseudocyst, but when it was very small in size, when it was not causing any compression, when it was less than 6 weeks. Okay, I've told you pancreatic pseudocyst needs a surgical intervention or a drainage if rule of 6 is there. That means more than equal to 6 weeks old, more than equal to 6 centimeters in size, or more than equal to 6 millimeters ka wall thickness. Okay, in this condition it will need a drainage, or if the patient is having any pressure symptom. Otherwise it does not need any drainage. Okay, if it is smaller, if it is asymptomatic. Clear? Hopefully this is done now. Now let's talk about carcinoma. Again, याद रखना, most common site, this is important, most common site for a pancreatic pseudocyst, previous year question, it is the lesser sac of omentum beta. So lesser sac of omentum is the most common site of pancreatic pseudocyst. Next, please remember, if they say carcinoma pancreas beta, we know carcinoma pancreas is also going to be an adenocarcinoma itself. The carcinoma pancreas can be at three sites mainly. First is the head and the body of pancreas. Second is the distal body or the tail of pancreas. And third is the periampullary cancer. What is the periampullary cancer? Can you see the green one? Green one is a carcinoma head of pancreas. Can you see the brown one? That brown mass is a carcinoma tail of pancreas. And can you see the pink ones beta? Those pink ones are the periampullary cancer. What do I mean by this? When the cancer is usually seen in and around the pancreatic duct beta. Yes. So we know that pancreatic duct opens at the ampulla of Vater at the second part of duodenum. So if the cancer is going to be around this region beta in the ampulla of Vater, it is called as definitely a periampullary cancer. Can anybody tell me, at ampulla of Vater we have special sphincters beta? One sphincter, definitely please tell me that how many sphincters are present in sphincter of Oddi? Sphincter of Oddi is actually collection of all the sphincters at the ampulla of Vater, in the common bile duct, in the main pancreatic duct, everywhere. So please tell me, this was a previous year question, what is the number of sphincters in the sphincter of Oddi at ampulla of Vater? So Do remember beta that the number of sphincters are four. There are four sphincters, out of which one is located in the main pancreatic duct, two of them are located in the common bile duct, and one of them is located in the ampulla of Vater beta. Not three, it's four. The total four sphincters definitely at the ampulla of Vater. Do remember that. Okay, sphincter of Oddi has four sphincters in it. So now, coming back to carcinoma pancreas. So please remember the tumor marker for carcinoma pancreas beta, it is nothing else but CA19-9, an important PYQ. So CA19-9 is definitely the tumor marker. Now, if they ask you, what is the investigation of choice? So do remember, investigation of choice, again, retroperitoneal organ. So investigation of choice has to be a CECT abdomen, except in one condition. See, I told you beta, usually we do not take a biopsy from pancreatic cancer, liver cancer, gallbladder cancer, or kidney cancer. Reason is, here if we try to take a biopsy beta, you may spread that cancer while you are removing the needle. That's the reason we do not take it, except in one condition. So all carcinoma pancreas, the investigation of choice is CECT abdomen, except in periampullary cancer. Why? Because in periampullary cancer, we can go via ERCP and we can take the biopsy without spreading it. Okay, so that is important beta. Periampullary cancer it is ERCP with biopsy, but other pancreatic cancer it is CECT abdomen. Now, in a patient of pancreatic cancer beta, when I do a barium meal follow through, on that barium meal follow through, I am able to see a very classical sign beta. If there is cancer in the periampullary region or the head of pancreas, I am able to see this classical sign beta, which is called as the E sign or the reverse 3 sign or the Frostberg sign beta. So E sign, reverse 3 sign or the Frostberg sign will be usually seen. Okay? And if they ask you about the treatment now, if I talk about treatment beta, do remember if there is a cancer in the distal body or the tail of pancreas, okay, I can just remove the distal body and the tail of pancreas, called as the distal pancreatectomy beta. That is known as distal pancreatectomy. But if they ask you if there is a cancer in head and head of the periampullary region, so carcinoma head of pancreas or the periampullary pancreatic cancer, here the treatment is this surgery beta, as you are able to see. This is called as a classical Whipple surgery. This has come as an image based question in your examination. Do remember that. Okay? This is the classical Whipple surgery where we are going to remove how many organs beta? We are going to remove, please remember, the gallbladder, the cystic duct, the common bile duct, the duodenum, the head and the neck of the pancreas beta. These are the structures to be removed. And after we remove these structures, we are going to perform three connections or three anastomosis. First is the pancreatico-jejunostomy. Second is the hepatico-jejunostomy. And third is the gastro-jejunostomy. Okay? The pancreatico-jejunostomy, hepatico-jejunostomy and gastro-jejunostomy are the three anastomosis that we perform after Whipple surgery. Now, please tell me, what is the most common complication of Whipple surgery? Previous year question of exam. Do let me know in the chat box. We have discussed that. What is the most common complication of Whipple surgery beta? Most deadly complication which can cause death is an anastomotic leak, because so many anastomosis are there now. It may leak and cause peritonitis in the patient. Okay? But most common complication is not leak. Anybody? What is the most common complication? It is the impaired gastric emptying beta. Okay? The food is not able to drain properly from the stomach into the duodenum. So impaired gastric emptying is seen usually in a case of Whipple surgery. Very good. That is important. Okay? Hopefully that's clear. Now another one which is there beta, it is this question out here. Please tell me a provisional diagnosis and then answer it. We have an elderly diabetic patient presents to the emergency room with fever, right upper quadrant pain and discomfort. On general physical examination beta, icterus is noted and palpation reveals tender hepatomegaly. CT abdomen is given below and blood culture comes positive. What is the most appropriate treatment for this patient? Follow. So, what is your answer? ABCD. Are you not going to mark in the examination? Examination skip करने का कोई option हमारे पास. So if that's not happens, why we are questions over आंसर ना, nobody judges you यार, nobody cares, literally वही बता रहा हूँ, कोई फर्क नहीं पड़ता है, लोगों को जज करने दो, doesn't matter, we are learning, that's more important. ठीक है, बोलो, what do you feel? Understand, elderly diabetic patient मतलब definitely the patient is immunocompromised, right? Along with that, the patient is having fever, right upper quadrant pain and discomfort. That is some problems related to the liver or gallbladder, it seems. General physical examination says that icterus is noted, that is jaundice is usually seen. Palpation reveals tender hepatomegaly. That means there is enlargement of the liver and there is pain when we do a palpation. Okay, so it seems to be a case of infection of the liver usually. An infection of liver leads to formation of pus or abscess in the liver beta, and blood culture comes out to be positive. This is diagnostic. What is your provisional diagnosis? Now here when I see a CCT beta, on that I am able to see definitely cavity inside the liver which contains pus. So it seems to be a case of liver abscess. We know there are two types of liver abscess beta which will be seen. Either it is a pyogenic liver abscess or a amoebic liver abscess. What do you think is this case suggestive of? Pyogenic or amoebic liver abscess? क्योंकि if it was a hydrated cyst beta, hydrated cyst में there is a cavity which is there, and in that cavity which contains fluid I'm able to see a floating membrane beta, giving us a classical floating water lily sign. So even if that floating water lily sign is not there, another reason to rule out hydrated cyst is because they have said that the blood culture of the patient is positive. We know hydrated cyst is a protozoal infection beta caused by Echinococcus granulosus. Please tell me, can Echinococcus granulosus or any other protozoa culture? No, culture cannot be positive for protozoa, na? So therefore it has to be a case of pyogenic liver abscess. Very good, because even amoeba cannot culture beta. Okay, culture will be negative for amoeba also. Therefore it has to be a case of a pyogenic liver abscess, which is a bacterial infection. Okay, so please remember beta, pyogenic liver abscess can be due to multiple bacteria together, but the most common cause, if they ask you worldwide, it is E. coli beta. The most common cause, if they ask you worldwide, it is E. coli, and in India or in Asia, if they ask you, answer is Klebsiella. Okay, pyogenic liver abscess is usually polymicrobial, but single best answer worldwide is E. coli. Asia में it is Klebsiella. Okay, so blood culture comes positive was a keyword of this question beta, and that's the reason. Now if I ask you what is the treatment, so answer has to be option D. Reason why option D beta, IV antibiotics will be given because it is a bacterial infection, and second, a pigtail catheter insertion should be done. Yes, and we know pigtail catheter insertion and drainage is always done under ultrasound guidance, blindly nahi karte ho, right? So ultrasound guided pigtail catheter insertion and drainage of pus is there. You will be like, say even option C will be right now. Yes, option C can be right, ultrasound guided drainage. But important is beta, we also give antibiotics now. So if I compare C and D both, which one is a better answer? D is a better answer because it contains both in the option. That's the reason. Yeah. याद रखना, percutaneous aspiration and injection of scolicidal agents, option A, which is there. Pair therapy, you know, pair therapy is the treatment which is done for a hydrated cyst beta, not for a pyogenic liver abscess. And metronidazole and diloxanide furoate, both are amoebicidal drugs beta. Both of them are given for amoebic liver abscess, not for a pyogenic liver abscess. Yeah, hopefully this is clear. Now we know that if I talk about the liver beta, so do remember liver is divided into the right and left lobe by which line beta? A line which extends from the gallbladder fossa below till the inferior vena cava above. Okay, a line that divides the liver into the right and the left lobe beta is called as the Cantley's line. Do remember that? Okay, so it is a Cantley's line. Then we also have a classification of liver beta which divides the liver into 8 segments. Yes, 10 segments in lungs and 8 segments in liver. So the classification of liver which divides the liver into 8 segments beta is known as the Coynard's classification. This Coynard's classification is based on the arrangement of portal vein and hepatic vein. How the portal vein and hepatic vein are arranged, according to that, you classify the liver into 8 segments. That is Coynard's classification. Out of which the segment number 1, which is there, you can see it is exactly in the center beta. That segment number 1 is also called as the caudate lobe beta. Segment number 1, which is exactly in the center of the liver, inside is called as the caudate lobe. Okay? Now important is, let's talk about the two types of liver abscess. First is the pyogenic liver abscess beta, and second is the amoebic liver abscess. I told you already, pyogenic liver abscess is a bacterial infection. Most common cause worldwide is E. coli. In Asia, it is Klebsiella. Amoebic liver abscess, by the name it is evident, it is caused by enta-amoeba histolytica beta. And we know amoebic liver infection, amoebic infection always occurs due to intake of contaminated food and water. That is the reason amoebic liver abscess is more common in alcoholic males. Okay, because they ingest contaminated food and water. Initially, amoeba enters into their intestine beta and it causes ulcers. Which shape ulcers are usually seen in intestinal amoebiasis? So do remember, flask shaped ulcers are seen in patients of intestinal amoebiasis, from where the amoeba penetrates the intestinal wall, it enters into the portal vein, and from the portal vein it reaches to the liver, causing liver abscess. Yeah. तो याद रखना, फ्लास्क शेप्ड अल्सर्स आर सीन इन इंटेस्टाइनल अमीबियासिस. कैन एनीबडी टेल मी दो टाइप के इंटेस्टाइनल अल्सर्स ऑल? वन, longitudinal ulcers is a feature of longitudinal intestinal ulcer. Longitudinal मतलब vertical straight. So longitudinal intestinal ulcers is a feature of, बोलो. Longitudinal intestinal ulcers is a feature of, very good, typhoid, very good, enteric fever or typhoid, shabash. Longitudinal intestinal ulcers is a feature of typhoid or enteric fever beta, whereas transverse ones, horizontal wale, transverse intestinal ulcers, anybody? Transverse intestinal ulcers is a feature of TB, shabash. So transverse intestinal ulcers is a feature of tuberculosis beta, shabash. ठीक है, तो ये तीन टाइप के अल्सर्स इंटेस्टाइन में याद रखना. अब स्टमक के भी बताई दो, इफ यू हैव कम ओवर हियर. Cushing's ulcer in the stomach are a feature of. Cushing's ulcers in stomach are due to. Cushing's ulcers in stomach are due to. Raised ICP beta, due to raised intracranial tension, that is in patients of head injury. So in patients of head injury, when there is a raised intracranial pressure, that may lead to Cushing's ulcers in the stomach. And very good, stress, yes. So, and if I talk about Curling's ulcers, anybody? Curling's ulcers. Burns, very good, yes. So Curling's ulcers in the stomach are a feature of burns. Shabash. So ये ulcers याद रख लेना. Now coming back to liver abscesses beta. As I told you, amoebic liver abscess spreads via the portal vein beta, and please remember it is more common in the right lobe of the liver in the postero-superior quadrant. That is segment number 7 and 8. Okay? So amoebic liver abscess is more common in the right lobe in the postero-superior quadrant. That is segment 7 and 8. Pyogenic liver abscess is not common in one quadrant. It is equally like seen in both the quadrants. Next important, if I talk about beta, that what are the common symptoms? So symptoms are going to be similar. The only difference which is there beta, it is based on the severity of symptoms. If I say the symptoms, what are those? First of all, the patient may have fever. Second, the patient may have icterus or jaundice beta. Third, the patient may have pain in the right hypochondrium. And fourth, the patient will have enlargement of the liver, that is hepatomegaly. Okay? The only difference is in pyogenic liver abscess beta, as it is a bacterial infection, the symptoms of the patient are going to be more severe. Whereas on the other hand, amoebic liver abscess beta, the infections are going to be mild to moderate. Okay? So severe symptoms are seen in pyogenic liver abscess, mild to moderate symptoms are seen in amoebic liver abscess. That is the difference. Now if they ask you what is the radiological investigation of choice for both the condition. For both the conditions beta, the radiological investigation of choice, if the patient is a small child, then it can just be an ultrasound abdomen. If the patient is a small child, then it is just ultrasound abdomen. But if the patient is an adult, then it is CECT abdomen. So radiological investigation of choice, for a child it is definitely ultrasound abdomen. For an adult it is CECT abdomen. Next important, if they ask you beta, what is the investigation of choice or the gold standard test overall? Okay, so for pyogenic liver abscess, the investigation of choice or the gold standard investigation will be a blood culture or a pus culture. What better than a blood or a pus culture beta, because it will directly show you the growth of the bacteria itself, telling you which bacterial infection it is exactly and which antibiotic should be given. Okay? So pyogenic liver abscess के लिए overall best investigation or investigation of choice is blood or a pus culture, and for amoebic liver abscess it is serology. Serology is study of antigen and antibody, and that is done by ELISA beta. So overall investigation of choice for amoebic liver abscess is ELISA. Now if they ask you treatment beta, treatment for a pyogenic liver abscess, we know as it is a bacterial infection, treatment has to be IV antibiotics first. Broad spectrum antibiotics should be given, something like ceftriaxone beta, which is a third generation cephalosporin. Okay, so ceftriaxone वगैरह देंगे पहले, IV ceftriaxone. But once the culture report comes out, then you know exactly which antibiotic to be given. Okay. After that, we also have to do a ultrasound guided drainage bit, and we know for the purpose of ultrasound guided drainage of liver abscess, we have to insert which catheter? TD pooch wala, that curved tail, that is pigtail catheter beta. For ultrasound guided pigtail catheter insertion and drainage of the pus has to be done. Next important, if I talk about amoebic liver abscess. In amoebic liver abscess, we have to give an amoebicidal drug beta, that is metronidazole. So drug of choice for amoebiasis, we know it is metronidazole. So we will give IV metrogel or IV metronidazole to the patient beta. If my patient's condition improves, then I'll continue metronidazole further and I will add another drug known as diloxanide furoate. Why? Because metronidazole can only kill the amoeba beta in the liver. If I want to kill the amoeba in the intestine also beta, I should give a luminal amoebicide, something like diloxanide furoate. Clear? Second important, after giving IV metronidazole to my patient beta, if my patient's condition does not improve, okay, or if my patient's condition worsens, then I have to go for a ultrasound guided drainage beta. Again, ultrasound guided pigtail catheter insertion and a drainage has to be done. Clear? And when I aspirate beta, the pus from amoebic liver abscess, from an amoebic liver abscess, when I aspirate the pus, it was classically like this beta in the picture, called as the anchovy sauce pus, also known as chocolate pus beta. So amoebic liver abscess mein the pus that we aspirate looks like this, known as the anchovy sauce pus or the chocolate pus. Next important is a hydrated cyst beta. We know hydrated cyst which is there, it is again a sac which contains fluid. Okay, it can be formed in multiple organs. Yes, hydrated cyst or hydrated disease can infect multiple organs beta, but the most common site infected is the liver, followed by the second most common lungs. Okay, most common organ affected by hydrated cyst is the liver, followed by lungs. If they say what is the causative agent of hydrated cyst, do remember that it is Echinococcus granulosus beta. Most common cause of hydrated cyst is Echinococcus granulosus. Do remember that. Okay. But if they say beta there is a single cyst, then the cause you can say Echinococcus granulosus. Previous year question where they gave a CECT, and in that CECT the liver was having multiple cysts beta. Now please tell me, if the liver is having multiple cysts, that is a case of malignant hydrated. And we know that multiple cyst or malignant hydrated cannot be caused by Echinococcus granulosus. Then what is the causative agent, anybody? If there are multiple cyst or malignant hydrated, that is caused by which Echinococcus, anybody? Single cyst is granulosus, multiple cyst नाम में याद है उसके बेटा. Very good, multilocularis, shabash. So Echinococcus multilocularis is the cause beta for multiple cysts inside the liver. Okay, so multilocularis नाम में ये multiple locations पे. Very good, shabash. ठीक है. Important is if they ask you beta what is the symptoms, symptoms are going to be same: hepatomegaly, fever, jaundice. Okay, so these are the kind of features, and discomfort in the right hypochondrium. Investigation of choice is also same, that is CECT abdomen. And when I do a CECT abdomen, you're able to see a cyst which has a floating membrane inside it, classically called as the floating water lily sign beta. Floating water lily sign is a classical feature of hydrated cyst. Treatment, if they ask you, we know the first line management is a pair therapy. What is pair therapy? Percutaneous aspiration, injection of scolicidal agents, and reaspiration. Matlab, we are going to aspirate all the fluid which is collected in the cyst. Then we are going to inject a scolicidal agent which is going to kill all the immature forms of the scolex of that Echinococcus beta, so that it doesn't lead to reaccumulation of fluid. And then whatever scolicidal agent we have injected, we have to reaspirate it back. Otherwise, it will cause damage. If they ask you which is the most common scolicidal agent injected to kill that, scolex of the Echinococcus beta, it is nothing else but 20% hypertonic saline. So the most common agent used is 20% hypertonic saline beta. The other ones can be mebendazole, cetrimide, alcohol, everything. If they ask you along with pair therapy, what is the drug that is given for the treatment of hydrated cyst beta, we know it is albendazole. So albendazole is the drug that we give along with pair therapy for the management of the patient. Okay? So that has to be remembered. We know that certain conditions where pair therapy cannot be done. Pair therapy is contraindicated in certain conditions beta. For example, if there is an impending rupture, that means the cyst can rupture at any point of time. Second, if there is a deep seated cyst beta, if there is a dead cyst or a calcified cyst beta, right? So usually in these type of conditions, we do not go for a pair therapy. So if pair therapy, if it is contraindicated, the next option is a surgery beta, where I am going to remove the cyst only beta. Okay, so if we have to remove the cyst along with that outermost covering, and that surgery is called as a cystopericystectomy. Okay, that surgery will be called as a cystopericystectomy. But if there are multiple cysts, then how many cystopericystectomies we are going to do now? So in that condition, if there are multiple cysts beta, we cut the part of the liver which is having that multiple cyst, and that is known as liver resection. Okay, So mainstay is pair therapy. If pair therapy is contraindicated and a single cyst is present, then cystopericystectomy. But if there are multiple cysts, then liver resection has to be done. Next important, we know beta if I talk about the liver tumors or the hepatic tumors. All the benign hepatic liver tumors which are, all the benign liver tumors which are there beta, they are more commonly seen in female. Reason? All the benign liver tumors are commonly associated with OCP, oral contraceptive pill intake beta. That's the reason they are more common in female. We know all the benign liver tumors are associated with OCP intake, but strongest association with OCP intake is seen with the benign tumor known as hepatic adenoma beta. Strongest association with OCP intake is seen with which benign liver tumor? Answer is hepatic adenoma. You remember that. And hepatic adenoma also has a 10% risk of cancer or malignancy. Other benign liver tumors may not have a risk of malignancy, but hepatic adenoma do have a risk of malignancy. If they ask you, beta, what is the investigation of choice for any liver tumor? So do remember, any benign liver tumor, investigation of choice is CECT abdomen, and the treatment is usually observation and follow-up. Okay? Except in hepatic adenoma, you may go for a liver resection because risk of cancer or risk of malignancy is there. Otherwise, all the other benign liver tumors, observation and follow-up is done. Okay? If they ask you what is the most common cancer or most common malignancy in the liver, answer is secondaries or metastasis. That means the cancer did not start from the liver. There was cancer somewhere else and from there it has spread to the liver beta. So most common malignancy in liver, if they ask you beta, answer is secondaries or metastasis. And we know what is the most common tumors from where it will spread? Colorectal cancer beta, right? So colorectal cancer, gastric cancer, esophageal cancer, from all of the GIT cancers beta, the cancer usually spreads to the liver only, right? Next, if they ask you which is the most common primary malignancy of liver, the most common primary malignancy of liver is a HCC, that is a hepatocellular carcinoma beta. Okay, it is nothing else but HCC, that is a hepatocellular carcinoma. Okay, the most common primary malignancy in the liver is HCC or hepatocellular carcinoma. And do remember that hepatocellular carcinoma can also be called as a hepatoma beta. Yes, do not get confused that hepatoma would be benign. No, hepatoma is an exception to be remembered, that hepatoma is a malignancy itself. And we know investigation of choice for hepatocellular carcinoma is a triple phase CT scan beta. Non-contrast, arterial phase and venous phase. So a triple phase CT scan is done and treatment is liver resection and a transplantation in cancer. Okay? If they ask you beta that which adulteration disease is associated with hepatocellular carcinoma beta, okay, which adulteration disease is associated with hepatocellular carcinoma, what is your answer? Do tell me that in the chat box. So answer has to be, hello, I'll just give you a hint. The patient, very good. The patient works in a groundnut industry beta. So definitely it's a classical case of aflatoxicosis beta. The aflatoxicosis is the condition where the patient may have a risk of developing HCC or hepatocellular carcinoma. Another question, important one beta, please tell me that PVC exposure, PVC is nothing else but polyvinyl chloride beta. So PVC or polyvinyl chloride exposure leads to which cancer of the liver? Polyvinyl chloride exposure leads to which liver malignancy? It is angiosarcoma beta. Please remember, PVC exposure is commonly associated with angiosarcoma, a malignancy arising from blood vessels beta. Angiosarcoma of liver is due to PVC exposure. Okay, that is important. Next, if they ask you which is the most common primary tumor in children beta, the most common primary liver tumor in children is nothing else but hepatoblastoma. Most common primary liver tumor in children is hepatoblastoma. And lastly, if they ask you which is the most common benign liver tumor, the most common benign liver tumor overall is nothing else but hemangioma. Hemangioma means again a tumor arising from blood vessel, but this time it is benign. So most common benign liver tumor is hemangioma, followed by FNH. And FNH is nothing else but focal nodular hyperplasia beta. FNH is nothing else but focal nodular hyperplasia. Now, next important if I talk about is gallbladder beta. So do remember, if I talk about gallbladder here, the first condition that I want to discuss is gallstones, also known as cholelithiasis beta. Gallstones or cholelithiasis is nothing else but the stones which are formed due to a concentrated or a lithogenic bile beta. Yes, if the bile is going to be more concentrated, it is going to have more amount of bile pigments, okay, or more amount of cholesterol in it. That may increase the risk of gallstones in the patient. If they ask you there are three types of gallstones, we know beta. One, which are made up of more than 90% of cholesterol, that is called as cholesterol gallstone. Second, which are made up of only the bile pigments like biliverdin and bilirubin, those are called as pigmented gallstones. And third, which are a mix of cholesterol and bile pigments, both called as mixed gallstone. If they ask you which is the most common type of gallstones overall, answer has to be mixed gallstones beta. If they ask you which are the most common type of gallstones in India or in Asia beta, most common gallstones in India or Asia, we know it is the pigmented gallstones. And if they ask you if there is a fat fertile female in her 40, that fat fertile female in her 40 beta is usually at a higher risk of developing cholesterol gallstones. Fat matlab obesity na, that is important. Okay? Now, majority cases of gallstones beta, these patients are going to be asymptomatic. It is just an incidental diagnosis. That means you are doing ultrasound for some other purpose and you get to know that the patient is having a gallstone. Sometimes the patient may have some problem beta, and that is usually pain. And that too, the pain arises after taking food beta, right? So please remember, the patient may have a main complaint, and that is pain in the right hypochondrium. And that pain is more severe after taking food as such. Okay? Some patients may develop jaundice, but that's less common. These are the main symptoms beta only, if symptoms are present. Investigation of choice, if they ask you, we know 90% gallstones are going to be radiolucent beta. That means they will appear black on X-ray or CT. So therefore, neither a X-ray nor a CT can be used for a gallstone. Investigation of choice has to be ultrasound abdomen. And on ultrasound abdomen, how do we differentiate a gallstone from a gallbladder polyp beta? I told you that gallstone is hard and therefore all the sound waves are reflected back. And therefore, I am able to see a posterior acoustic shadowing. Can you see this blue one highlighted? So posterior acoustic shadowing, if it is seen beta, it is a case of a gallstone. But if posterior acoustic shadowing is not seen, it is a case of a gallbladder polyp. Clear? So if shadowing seen, it is a stone. If shadowing not seen, it is a polyp. Then I may also go for a CECT abdomen, and when we do a CECT abdomen in a patient of gallstone, I am able to see a classical sign called as the Mercedes-Benz sign beta. Mercedes-Benz sign can also be seen. Now, if they say what is the treatment, we know the treatment for gallstones or for cholelithiasis is nothing else but better a removal of the gallbladder, that is called as cholecystectomy beta. And cholecystectomy can either be an open cholecystectomy or a laparoscopic cholecystectomy. In open cholecystectomy, we give an incision in the right hypochondrium beta, and this incision in the right hypochondrium for the open cholecystectomy is called as the Kocher's incision beta. Do you remember the name of the incision? It is known as the Kocher's incision. For open cholecystectomy, it is given. Clear? Next important is a condition beta is this. Here you are able to see definitely this is the gallbladder, and on the gallbladder wall you are able to see these yellowish cholesterol deposits. Okay? So if there is more amount of cholesterol in the bile, it may deposit on the gallbladder wall, and that will give you a classical appearance known as the strawberry gallbladder beta. Okay, so strawberry gallbladder which is there, it is usually seen in a patient suffering from cholesterolosis of gallbladder. So cholesterolosis of gallbladder is usually giving an appearance called a strawberry gallbladder. इधर ही बाकी strawberries बताई दो एक बार. I'll just ask you. You may revise other subjects also. जल्दी से बोलो. Strawberry vagina. First condition, strawberry vagina, also called as angry looking vagina, also called as colpitis macularis, is seen in. The first is strawberry vagina. Very good. Trichomoniasis beta. Yes, it is seen in trichomoniasis. Next condition, if I ask you, strawberry tongue is usually seen in which infection? I'm asking infection. Huh? Strawberry tongue is seen in which infection? Infection बोल रहा हूँ, सोच समझ के आंसर करना. Very good. One, scarlet fever is the infection. Okay. Yes, scarlet fever is the infection. And second, if I talk about a vasculitis, a medium vessel vasculitis known as Kawasaki disease. Very good. So strawberry tongue is seen in an infection known as scarlet fever, or it can be seen in a vasculitis known as Kawasaki disease. You remember that. Last, if I talk about strawberry gums, strawberry gum, strawberry gum. It is seen in vaginous granulomatosis. Do you remember strawberry gums are a feature of vaginous granulomatosis? Okay? So it is seen in vaginous granulomatosis. Next important. This is a condition beta. We know here you are able to see a CECT abdomen where the wall of the gallbladder appears to be white beta. Why? Because there is calcification of the gallbladder wall. And if there is calcification of the gallbladder wall, beta, this condition is known as porcelain gallbladder. Now, important to be remembered, beta, do remember this, that the porcelain gallbladder which is there, it is actually a pre-malignant condition. Yes, the porcelain gallbladder which is there, it is actually a pre-malignant condition, beta. It may develop into a cancer. Okay? So do remember that porcelain gallbladder is pre-malignant in nature and it may develop into a cancer. Okay? So here a cholecystectomy will be required. Okay? A cholecystectomy has to be required. Next important is this condition where they say a patient presents to you with sudden onset right upper quadrant pain, fever, nausea and vomiting, beta. The sign below given is elicited. Now what is this sign? When you are going to palpate the right hypochondrium, beta, the patient will have a lot of pain and due to that the patient will catch his own breath. सांस पकड़ लेगा बेटा. Okay, so please remember this is classically called as the Murphy's sign. So when you palpate, the patient catches the breath, known as the Murphy's sign, and it is a classical clinical sign elicited in a patient of acute cholecystitis, beta. It is seen in a patient of acute cholecystitis when there is inflammation of the gallbladder. Investigation of choice for acute cholecystitis, beta, we know it is ultrasound abdomen for a child, okay, or even for an adult. So investigation of choice for acute cholecystitis is an ultrasound abdomen, and gold standard investigation, if they ask you, answer is a HIDA scan, beta. Gold standard investigation is a HIDA scan, that is hepatic immunodiacetic acid scan. Treatment has to be conservative management, beta. You will just do the same 4 things that we did in conservative management. You have to do conservative management. Surgery is not immediately done in case of acute cholecystitis because as the gallbladder is inflamed now, it will be adhered to a lot of structures. There will be a lot of adhesions. If you try to remove the gallbladder, you may damage the other structures. That's the reason. Next important is this triad bit over here. What is this triad? Here I am able to see that the gallbladder appears black because there is presence of air or gas inside the gallbladder. That is called as pneumobilia, beta. Second, we are able to see multiple air fluid levels in the intestine. Why? Because air fluid levels in the intestine, we know it is seen in patients of intestinal obstruction or a small bowel obstruction. And third, I'm able to see a radio opaque shadow or a gallstone in the terminal ileum. So, pneumobilia, small bowel obstruction, okay, and gallstone in the right iliac fossa or in the terminal ileum is a classical triad known as, बोलो क्या बोलते हो इस triad को? This is a classical triad, beta, known as, anybody? Yes, it is seen in gallstone ileus, beta. We know it is seen in gallstone ileus. What is the name of the triad, beta? What happens in gallstone ileus? That there is a adhesion between gallbladder and the duodenum, beta, and then there is formation of fistula between gallbladder and duodenum. So that the stone from the gallbladder slips into the duodenum, it travels all the way to the terminal ileum and causes a small bowel or intestinal obstruction. Okay? Whereas some gas goes from the intestine to the gallbladder leading to this pneumobilia. Very good. It is classically known as the regular triad, beta. Shabash. So regular triad is seen, and this is the diagnosis of gallstone ileus. No issues with this. Hopefully this is clear. Okay. Next important question, if I talk about, beta, is this one. Answer this question out here. First question, a 52-year-old woman on the waiting list for a laparoscopic cholecystectomy has been admitted as an emergency with increasing right upper quadrant pain, swinging pyrexia, that is fever is on and off, and extreme tenderness over the gallbladder. She is toxic and has leukocytosis with raised inflammatory markers like CRP, ESR, all of that. Ultrasound of the gallbladder shows a thickened gallbladder enveloped by omentum. Omentum has got stuck around the gallbladder with pericholecystic fluid. What is the likely diagnosis? What do you think? See, it is not a case of biliary colic. Reason is definitely here the patient is having features like there is right upper quadrant pain. Chalo, upper quadrant pain can be seen in biliary colic, but swinging fever, extreme tenderness, these raised inflammatory markers, leukocytosis, obviously these are all signs of infection or inflammation, which is not a feature of biliary colic. Biliary colic means a stone gets obstructed in the bile duct and that may lead to pain, beta. So in that condition, a lot of infection is not seen. Next, acute cholecystitis. Yeah, acute cholecystitis can be close differential. Next is carcinoma of gallbladder. Carcinoma of gallbladder will have a longer history with weight loss and all other features as well, beta. So carcinoma is also not the option. We are actually thinking about either A or D. A is acute cholecystitis, D is empyema of the gallbladder. Answer jaldi. The diagnosis here seems to be a case of an empyema of gallbladder. What is empyema? But empyema is nothing else but pus collection in the gallbladder. So now we know even acute cholecystitis is inflammation, and even empyema is the infection and inflammation beta. But acute cholecystitis may present to us with mild symptoms of infection or inflammation beta. Here there are very severe symptoms. They have said that the patient appears toxic to you beta. Okay, so if the patient appears toxic, that means it is a severe infection or a severe inflammation, likely suggestive of empyema of the gallbladder. So if I have to choose one between A and D, my answer would be D, that is empyema of gallbladder. Clear? Now answer the next question, beta. A patient was diagnosed as a case of acute cholecystitis and he was a known case of gallstones. The patient was managed conservatively and then planned for an interval cholecystectomy. Patient undergoes a laparoscopic cholecystectomy. He started developing pain in the right hypochondrium and fever. And therefore an ultrasound was done which reveals a 5 by 4 centimeters of fluid collection under the liver. What shall be done next? Follow. A, B, C, D. What is the answer? Up some. With some other answer now. तो जो भी लग रहा है, whatever you think, doesn't matter. Yes, after surgery, definitely the patient has come to you and he has started developing pain in the right hypochondrium and fever. Ultrasound shows a 5 by 4 centimeter fluid collection. Now, definitely after a cholecystectomy, beta, if the patient comes back to you, after a cholecystectomy, if the patient comes back to you, beta, that means there has been some injury to the bile ducts during the surgery. And as there was some injury to the bile ducts during the surgery, what has happened? The bile was leaking beta, and as this bile was leaking, there was a collection of bile which has formed in the abdomen of the patient. Can you see? They are saying that ultrasound reveals a 5 by 4 centimeters of fluid collection. So this fluid collection is nothing else but collection of bile under the liver beta, and this is called as a bilioma. So we know whenever there is a major bile duct injury after surgery, it may lead to a major leak and collection leading to known as a bilioma. In biliomas, beta, we have discussed the stepwise management. The first step in a bilioma should always be, so please remember, the first step in a bilioma should always be an ultrasound abdomen beta. And once you do an ultrasound abdomen, you will be able to see that collection. Okay? As there was leakage of bile into the abdomen beta, due to that the patient was having pain, fever and all of these symptoms. Okay? So now whenever a patient comes to you with bilioma after surgery, first step is ultrasound abdomen. After ultrasound abdomen has been done and you see how much fluid collection is there and what kind of leak it is, everything, then definitely you will go for a pigtail catheter insertion. Yes, under ultrasound guidance itself, you will insert a pigtail catheter and drain all the fluid which is collected. After the pigtail catheter insertion has been done beta, then you have to see the injury or you have to see the damage to the bile duct beta. And to see the bile duct injury, you will definitely go for MRCP or ERCP beta. Investigation of choice for bile duct problems, we know it is MRCP. But if MRCP fails to make a diagnosis, then we may go for a better investigation. The gold standard investigation for bile ducts, we know it is ERCP beta. But if MRCP or ERCP both fail to make a diagnosis beta, then we know the most sensitive investigation for bile duct is a HIDA scan. So then if MRCP or ERCP fails, then we can go for the most sensitive investigation known as the HIDA scan beta. Now, if the patient has presented to us within 2 days of surgery beta, as the patient has presented to us early within 2 days of surgery, the contamination would be less and therefore we can take up the patient immediately for a surgery and repair it again. That is called as re-exploration and repair should be done. But if the patient has presented to us late beta after 2 days of surgery, that means now this bile collection would have led to sepsis also beta. And if the patient has presented to us late more than 2 days, patient would have more contamination or higher chances of sepsis. So in this condition, we go just for a ERCP and stenting. Okay? So that has to be done. Now please tell me what is the answer for this question then? A, B, C, D. Very good. Because they are asking what shall be done next, beta. And we know the first step is ultrasound abdomen, which they have already told they have done, and they are able to see a 5 by 4 centimeters of mass. So now the next step has to be drain all that fluid. That is done by option D, pigtail catheter insertion. The next step would be pigtail catheter insertion, beta. Now you know the flow chart. Clear? So hopefully this is clear to all of you. A very common question, bile duct injury in your examination in the recent times. Okay? If I talk about bile duct injury, beta, if you are able to suspect a bile duct injury during the surgery itself, then you have to see whether it is a partial injury or a complete transaction, beta. If there is partial injury, that is injury only to one side of the bile duct, then I can go for immediate repair. See, I am able to see a bile duct injury during the surgery is going on. So definitely if it is a partial injury, patient is open in front of me, surgery is going on, I'll immediately repair that partial injury. If there is a complete transaction means this is a complete transaction, beta, complete cut in the bile duct. If there is complete cut or complete transaction of the bile duct, beta, then I have to see if both the ends of the bile duct are present. That means there is no loss of any segment of the bile duct, nothing is missing over here. I can immediately go for a repair, but I know if I repair the bile duct, the sutures may break if the bile comes in contact with them immediately. Therefore, for some days, beta, for a few days, I have to insert a T-tube inside it. So if there is complete transaction and there is no loss of segment, I'll just go for immediate repair or an anastomosis, but I have to also insert a T-tube. So anastomosis over a T-tube has to be done so that the sutures do not break. Next, if there is complete transaction, beta, but this time one part of the bile duct is missing. Now see, there is complete transaction and one part of the bile duct is missing, beta. In this condition, what I do, I pull up your jejunum and I connect that jejunum directly to the common hepatic duct. When we connect a jejunum to the common hepatic duct, that is known as Roux-en-Y hepaticojejunostomy, beta. That is known as Roux-en-Y hepaticojejunostomy. Next, after surgery, if there is bile leak, beta, I have told you if there is a minor leak after surgery. So please remember, if there is minor leak after surgery, the patient will be stable. There will be no sepsis. There will be no symptoms in the patient. Patient will be completely asymptomatic. Just on a routine ultrasound, you are able to see, okay, there is somewhat leak, very minor leak. So in this condition, no intervention is required, because if that leak is minor, the injury is smaller, it will heal by itself. But after a surgery, if there is a major leak, beta, that may lead to formation of a bilioma, I told you, a fluid collection, and that may land up your patient into sepsis also. For that, I've discussed already ultrasound, pigtail catheter, MRCP, if it fails ERCP, if it fails HEDA scan. And once you diagnose that bile duct injury, if the patient has come to you early within 2 days, then immediate re-exploration and a repair. But if the patient has come to you after 2 days, then you have to go for ERCP with stenting. Okay? Yes. Next important condition, beta, is a neonate has progressive jaundice at birth, beta. So at birth itself, the patient is having jaundice. We know neonates में physiological jaundice is seen, but physiological jaundice starts from day 2 of life, beta, and it usually subsides by 2 or 3 weeks maximum. But if the jaundice is lasting for 2 weeks, if the jaundice is lasting for more than 2 weeks, beta, or the jaundice is lasting for more than 3 weeks, then in that condition, beta, we have to suspect a problem in the child. And what is that problem? It is biliary atresia, beta. What do I mean by biliary atresia? Yaad rakhna. In biliary atresia, the jaundice may last for more than 2 to 3 weeks. Here, the jaundice will be very severe. It will be progressive. That means it is increasing with time, and it is starting from birth itself. The jaundice starting from birth, lasting for more than 2 to 3 weeks, and it is increasing with time. That is progressive in nature. Classical diagnosis of biliary atresia, where the bile ducts are not formed, beta. Now, when I talk about jaundice, obviously the serum bilirubin level of the patient will be elevated. So total bilirubin is elevated and conjugated bilirubin is elevated. We know when conjugated bilirubin is elevated, it is likely to be a case of a post-hepatic jaundice or obstructive jaundice. Post-hepatic or obstructive jaundice, matlab there is some problem in the bile duct or the biliary tree, beta. And another feature which will tell you apart from the lab, beta, is pale stools and dark urine. Whenever the patient has, yaad rakhna, one thing I'm making very clear. Whenever a patient has a post-hepatic jaundice or an obstructive jaundice, it is due to some obstruction or some problem in the bile duct. Clear? If there is obstructive jaundice, beta, the patient will not have the bile coming into the intestine. Therefore, the feces of the patient or the stools of the patient will be pale in color or clay colored, beta. So if they say pale colored stools or clay colored stools, beta, along with a darker urine, that is a feature of obstructive jaundice. So pale stools, dark urine, obstructive jaundice. Second, lab mein I told you in obstructive jaundice, total bilirubin will be elevated, conjugated bilirubin will be elevated, and ALP levels are high. ALP is what? Alkaline phosphatase. याद रखना liver diseases में, if it was a hepatic jaundice, liver वाला problem, then AST and ALT would have been high. AST and ALT. But if there is any problem in the bile duct, then ALP is the enzyme which will be elevated. Beta. ALP. Now important is in biliary atresia, the bile duct is not formed. There are three types of biliary atresia. Type 1 is atresia of the common bile duct. Type 2 is atresia of the common hepatic duct. And type 3 is atresia of the right and the left hepatic duct. So type 1 में CBD नहीं बनती, type 2 में CHD नहीं बनती, and type 3 में right और left hepatic ducts ही नहीं बनते. ठीक है? That is important. Now if they ask you investigation of choice, so do remember it is HIDA scan. HIDA scan was the gold standard investigation for acute cholecystitis, and it is the investigation of choice for biliary atresia. If they ask you treatment, so understand in type 1 beta the common bile duct is not formed. तो वापस बराबर कौन से दोस्त को उठाओगे? अपने वेले दोस्त को, that is jejunum. You'll pull up your jejunum beta and you are going to connect your jejunum to the common hepatic duct. So in type 1 biliary atresia beta, the surgery is known as Roux-en-Y hepaticojejunostomy beta. Roux-en-Y hepaticojejunostomy. Whereas in type 2 or type 3 beta, in type 2 or type 3 definitely the bile ducts are not properly formed. In this condition, you directly do a portoenterostomy, also known as which surgery? Kasai surgery beta. So type 1 biliary atresia, the treatment is Roux-en-Y hepaticojejunostomy. Type 2 and type 3 biliary atresia, the treatment is Kasai procedure or Kasai surgery. Important PYQ. याद रखना है बस. ठीक है? Now important is beta, if they say that pain, fever and jaundice, we know this pain, fever and jaundice is a classical triad beta, which is known as the Charcot's triad. And where do we see Charcot's triad? So do remember that Charcot's triad is seen in patients of cholangitis. Now what is cholangitis? Infection or inflammation of the bile duct. So when there is infection or inflammation of the bile duct beta, we are able to see the Charcot's triad, that is pain, fever and jaundice. Along with pain, fever and jaundice, if I add shock, that is hypotension, and mental obtundation or mental confusion, then this becomes a pentad beta. What is this pentad called as? Pentad of cholangitis is known as, please tell me, pain, fever, jaundice, hypotension and mental confusion or mental obtundation is a pentad known as. So it is classically known as the Reynolds pentad beta. Do remember the triad is Charcot's triad and the pentad is Reynolds triad. Okay? So Reynolds pentad, which is there, definitely it is a feature of cholangitis itself. Reynolds pentad, yaad rakho. Yes. Next, this X-ray which is there beta, this is nothing else but a T-tube cholangiogram. Here you are able to see the bile ducts beta, that is called as a cholangiogram, and as you are also able to see the T-tube over here, this is what is considered as a T-tube cholangiogram. Next investigation in the picture is a ERCP beta, because you are able to see all the bile ducts. Along with that, you are also able to see the endoscope. So this is the endoscopic retrograde cholangiopancreatography, ERCP. We know ERCP is the gold standard or the best investigation for bile duct pathologies beta. So what is the investigation of choice then? If ERCP is the gold standard investigation for bile duct pathologies, what is the investigation of choice for bile duct problems? Very good, MRCP. Shabash. So bile duct problems के लिए do remember investigation of choice is MRCP and gold standard is ERCP. Shabash. Reason, MRCP is non-invasive and ERCP is invasive. And ERCP also, ERCP does not only make the diagnosis, also helps us in treatment as well. Next is a choledochal cyst beta. If I talk about a choledochal cyst out here, we know it is nothing else but dilatation of bile duct. Yes, if there is dilatation of some part of the bile duct beta, that is known as a choledochal cyst. Here, the patient will have a classical triad beta, and that triad is called as choledochal triad. Now, what is different between choledochal and a Charcot's triad? Charcot's triad was due to infection of cholangitis, so it had pain, fever and jaundice. But here it is just due to a cyst beta, so here fever will not be present. Okay? So in choledochal triad beta, there is a pain, lump and jaundice. Okay? So there is a pain, lump and jaundice. Pain, fever and jaundice, Charcot's triad. Pain, lump and jaundice, choledochal triad beta. Okay? So that has to be remembered. The classification that is used for choledochal cyst is known as the Todani's classification. Remember the name. Okay? And according to Todani's classification of choledochal cyst, we classify choledochal cyst into 5 types, where 4 is subdivided into 4A and 4B as well. First one, in type 1 choledochal cyst beta, there is a single extrahepatic cyst, and this single extrahepatic cyst is seen in the common bile duct beta. Okay. Next, type 2, which is there beta. Here there is an extrahepatic diverticulum. Yes, there is a diverticulum or outpouching from the common bile duct. Type 3, it is known as a choledococele, and in type 3 or a choledococele, the intraduodenal part of common bile duct gets dilated. The intraduodenal part of CBD gets dilated. Type 4A, in type 4A there are multiple extrahepatic as well as intrahepatic cysts. So type 4A mein there are multiple extra as well as intrahepatic cysts beta. Type 4B, there are multiple extrahepatic cysts only, multiple cysts but outside the liver. So multiple extrahepatic cyst only is a feature of type 4B. And type 5, multiple intrahepatic cyst only. Type 5 is also known as Caroli's disease beta. Do remember this. This was a PYQ. That Caroli's disease is which type of a choledochal cyst? Answer was type 5. And it is nothing else but multiple intrahepatic cysts only. If they ask you investigation of choice, abhi bola maine bile duct problems ke liye it is MRCP. Gold standard investigation if they ask you, answer is ERCP beta. Okay, and most sensitive investigation if they ask you, I told you HIDA scan. Treatment if they ask you. In type 1, what was the problem beta? In type 1, there was a single extrahepatic cyst in the common bile duct. So what we do, we actually remove the common bile duct and we pull up the jejunum and connect it to the common hepatic duct. When I pull up the jejunum and connect it to the common hepatic duct, this surgery is known as Roux-en-Y hepaticojejunostomy. Important and easy to remember. Type 1 biliary atresia and type 1 choledochal cyst is treated by the same surgery known as Roux-en-Y hepaticojejunostomy. Clear? Type 2 mein extrahepatic diverticulum was there. So we have to cut the diverticulum and we have to repair the common bile duct. Type 3 mein there was a choledococele or the intraduodenal part of CBD was dilated. Here we do a ERCP. We give a cut on the sphincter so that the mouth of the common bile duct opens properly and it does not cause any dilatation. So type 3 choledochal cyst mein it is ERCP with sphincterotomy. Type 4A and type 5 beta. What is the common feature between type 4A and type 5? In both the conditions, there were multiple intrahepatic cysts beta. As there were multiple intrahepatic cysts beta, we cannot treat it surgery. The only option left for them is liver transplant. So type 4A and type 5 ke liye liver transplant is the best one. And type 4B, where there were multiple extrahepatic cysts beta, so type 4B ke liye we can go for a Kasai surgery. So do remember type 2 and type 3 biliary atresia and type 4B choledochal cyst is treated by the same surgery, that is Kasai surgery. Okay? That is important. Now answer this question out here. What is this? Which among the following is type 3 choledochal cyst according to the Todani's classification beta? Type 3 choledochal cyst they are asking. A, B, C, D. What do you think? PYQ this is. Very good. B. Right? The B one which is there beta, here you are able to see that the intraduodenal part of the CBD is dilated and that is forming a choledococele beta. That is what is a type 3 choledochal cyst. Shabash. That has been a previous year question, so do remember. So type A is which one beta? Option A is which one? Option A is which type? Option A is which type? Option A is type 1 beta. Option A is type 1 because the CBD appears to be dilated. There is a single cyst in the common bile duct. So it is a single extrahepatic cyst. Yes. So option A is type 1. Option C batao. Option C. Option C is which type? Type 4 which one? 4B. Very good. So option C mein there are multiple extrahepatic cyst beta. Therefore type C, option C which is there, it is type 4B beta. Okay, it is type 4B. And type 4A is option D. Type 4A definitely is option B beta. No, option D is not type 5 beta. Option D is not type 5. Reason is, do remember that in option D you are able to see multiple intra as well as extrahepatic cyst also. So it is type 4A, not type 5. Okay. चलो मूविंग फर्दर यूरोलॉजी के साथ. इफ आई टॉक अबाउट यूरोलॉजी बेटा, now the first one which you are able to see over here which is nothing else but a CCT which is showing you there is a pair of bilateral ectopic kidney. Both the kidneys are not in their original position. They're ectopic in nature, beta. And do remember, the lower poles are fused in the midline, leading to formation of a U-shaped or a horseshoe shape, beta. So the first picture is showing you a horseshoe shaped kidney, and horseshoe kidneys mein the lower poles of the kidneys are usually fused together. Most common site of fusion, if they ask you, answer is L3, L4. Most common site of fusion, if they ask you, answer is L3, L4. Single best answer, if they ask you, beta, then your answer is L4. Okay, single best answer, if they ask you, answer is L4. If they ask you that in a case of horseshoe kidney, what is the symptoms? I told you, beta, due to horseshoe kidney, the patient may have UTI, the patient may have stones. Okay, these kind of features will develop. Investigation of choice is a CECT abdomen, beta. Okay, retroperitoneal organ. So investigation of choice is CECT abdomen. If they ask you, beta, what is seen on the IVP, the classical sign or the classical appearance in horseshoe kidneys, beta, on IVP will be called as, what is this appearance called as? Hand joining sign, hand shaking sign, or the flower vase appearance. So IVP in horseshoe kidneys gives us a very classical flower vase appearance, hand joining sign, or the hand shaking sign, beta. Please tell me for the treatment. Okay, so please remember, for the treatment in cases of horseshoe kidney, beta, please do tell me, will we go for resection of the kidney? Will we go for cutting the kidneys, beta? Do we cut that fused kidneys? ERCP is easy, beta. When you are able to see an endoscope along with all the bile ducts, that is what is the ERCP. MRCP, I'll show you the image. I'll send you the image though. Okay. So, or we will discuss it in this one also, in TNDs. Okay. I'll bring one image of MRCP as well. No, very good. That is important, beta. Do remember that. Please remember, resection of kidney is never required, because if you do the resection, that will cause damage to the kidney. Only supportive care or symptomatic management is done in horseshoe kidney. Shabash. Next, another condition is when your IVP is showing you a classical feature, beta, and this IVP is showing you dilatation, okay, of the ureteric openings, beta, and this dilated ureteric openings is giving you which kind of appearance? Idhar hi batao. This dilated ureteric openings is giving you a classical cobra head or adder head appearance, beta. And this cobra head or adder head appearance on IVP is a classical feature that is seen in a case of ureterocele, beta. And we know in cases of ureterocele, it can be unilateral or bilateral. The treatment is a ureteric reimplantation. Make a new opening for the ureters into the bladder, beta, because this opening is having a narrowing, and that is the reason this ureterocele is formed. Okay, cobra head or adder head appearance. Next, what is seen on this IVP? What is this sign called as? On this IVP, what is the sign called as? So this is very good. This is the drooping lily sign, beta. So here you are able to see on the right side, you can see, beta, on right side the renal pelvis which is there, beta, it appears like this because it is drooping lily sign. So if they say there is a drooping lily sign on IVP, we know it is a classical diagnosis of duplex renal pelvis and ureter, or duplication of renal pelvis and ureter. That means from one kidney there is one pelvis, beta, but here from one kidney there are two pelvis, and as there are two pelvis, beta, the upper pelvis is pushing down the lower pelvis. The upper pelvis is pushing down the lower pelvis, and therefore the lower pelvis appears like a drooping lily, beta. Okay? So duplex renal pelvis and ureters will give us a classical drooping lily sign on IVP. In this condition, we know, beta, both the ureters are going to fuse together and they are going to open as one single ureter, beta. That will not cause any problem. But sometimes what happens, both the ureters open up separately. One ureter normally opens into the bladder, but the other ureter becomes ectopic. And if that other ureter becomes ectopic, beta, it may lead to urinary tract infections, or it may lead to a dribbling or leakage of urine, beta. And in that condition, the treatment is reimplantation of that ectopic ureter into the bladder. Yes, pull out that ectopic ureter and make a new opening for that ureter into the bladder itself. Next, what is this picture? Here we have a neonate, beta, and that neonate would have these kind of a feature. What is this condition now? Follow. Neonate or an infant maximum. Okay? So a neonate or infant is having these kind of problems, beta. Here the child is not able to pass the urine properly. There is retention of urine over here, and due to retention of urine, there is dilatation of the renal pelvis and the renal calyces. As there is dilatation of renal pelvis and calyces, beta, there is hydronephrosis which has happened. Very good. Yes. Hydronephrosis, why? But what is the cause of hydronephrosis? Because we know hydronephrosis may occur due to multiple reasons. And we know the most common congenital cause of hydronephrosis, very good, it is PUG obstruction. Shabash. The most common congenital cause of hydronephrosis, beta, it is PUG obstruction. So basically, hydronephrosis is nothing else but dilatation of the renal pelvis and the renal pelvis and the calyces, and it can happen if there is a partial or a complete blockage to the flow of urine. Here, the blockage to the flow of urine is because the pelviureteric junction which is there, beta, it is obstructed, and as the PUG or the pelviureteric junction is obstructed, therefore the urine is not able to drain properly, and that leads to hydronephrosis, beta, not renalogenesis. भाई कहाँ renalogenesis दिख रहा है तुम्हें? ठीक है, please remember it is most common congenital cause of PUG, most common congenital cause of hydronephrosis is PUG obstruction. In PUG obstruction, beta, do remember that the surgery that we do is called as a Anderson-Heinz pyeloplasty, beta. Okay, the surgery that we do is known as the Anderson-Heinz pyeloplasty. No issues with this, anybody? Has to be remembered. Now, the next condition which is there, beta, here you are able to see that here also the renal pelvis and the calyces appears to be dilated, beta, and as the renal pelvis and calyces are dilated, it is also hydronephrosis. But what is the cause of hydronephrosis over here? So you can see that the ureter which is there, beta, the ureter is taking a turn and it is going behind the inferior vena cava. In this picture, you can see it clearly. Here, can you see? The arrow is marking towards the ureter. That ureter has taken a turn. Normally, ureter should go straight downwards. Here, the ureter is taking a turn and going behind the inferior vena cava. And due to this curvature, beta, there is blockage to the flow of urine, and therefore the patient develops hydronephrosis. Right? So do remember that. Here in this condition, definitely, bache, this is called as a retrocaval ureter. We know that if I talk about retrocaval ureter, bache, ठीक है, retrocaval मतलब when the ureter goes behind the inferior vena cava. We know retrocaval ureter is more commonly on the right side, बेटा याद रखना ये बात. Retrocaval ureter is more commonly seen on the right side as compared to the left one. ठीक है, and here you will get definitely the fish hook or the reverse J-shaped ureter. This curved ureter which is there, beta, it will give you a classical appearance called as a fish hook ureter or the reverse J-shaped ureter. Next is the paintbrush appearance. If on the IVP or IVU you are able to see a paintbrush appearance, beta, we know paintbrush appearance on IVP is a classical feature of medullary sponge kidney. Okay, paintbrush appearance is seen in medullary sponge kidney, which is due to dilatation of collecting ducts, beta, and the treatment is supportive over here or symptomatic over here. Next, now moving further, this is a condition, beta. What is seen? Here, the gross appearance of kidney shows multiple cysts, beta, which contains fluid in them, due to which the kidneys are completely damaged. Second, even the CCG abdomen shows you that the kidneys are having multiple cysts inside them, beta. This is a classical case of PCKD, bache. PCKD is nothing else but polycystic kidney disease. Now, in polycystic kidney disease, beta, there are two varieties, autosomal recessive and autosomal dominant. The autosomal recessive variety is called as the infantile variety, beta. And we know the autosomal recessive or the infantile variety, the child is not able to live, okay, or that variety is incompatible with life. The baby is not going to be alive for a longer time. Okay? Whereas the patient who comes to us with polycystic kidney disease is usually the AD, that is the autosomal dominant variety. Yes. So autosomal dominant variety is the one which presents to us commonly, beta. And in that autosomal dominant, it is due to a gene mutation. The gene mutation is known as PCKD1 or PCKD2. Or we can even call it as polycystin 1 or polycystin 2 gene mutation. Now this autosomal dominant variety is also called as a congenital PCKD because these gene mutations are present since birth, or it is also known as an adult PCKD because the symptoms will only appear after 30 years of age, when the kidneys have been completely damaged after a lot of cysts have been formed. Now please remember, what is the most common symptom in a patient of PCKD, beta? Please tell me that. What is the most common symptom in a patient of PCKD? What is the reason why the patient will present to you? So, as the kidneys are damaged, beta, there is volume overload in the body which develops, and due to that the patient will have hypertension. Very good. So do remember that, beta, the most common symptom in a patient of PCKD is nothing else but hypertension. The most common symptom in a patient of PCKD is nothing else but hypertension. Even the most common cause of death which is there, beta, the most common cause of death is also the same, that is nothing else but hypertension related complication. The most common cause of death is also the same, hypertension related complications itself. Investigation of choice, we know it is CCD as you are able to see in the picture, but IVP will give you a classical appearance, and that IVP is going to give you a spider leg appearance beta. IVP in patients of PCKD gives us the classical spider leg appearance. If they ask you about the treatment, we know antihypertensive drugs should be given. Which antihypertensive drugs are preferred in a patient of PCKD? Please tell me in the chat box jaldi se. When the hypertension is due to kidney damage, what are the drugs preferred usually? Let me know in the chat box. And the final and the definitive management right is renal transplant. Best treatment will be renal transplant. Very good. If there is hypertension due to kidney damage, beta, the best drugs to be given are ACE inhibitors or ARBs. Very good. Shabash. ACE inhibitors or ARBs. Follow now. What is this? Whether it is a Staghorn calculi or a putty kidney. Two options you have. Either it is a Staghorn calculi or a putty kidney. What do you think it is? Very good. Now, please remember, beta, I have always told you, if you are confused always to differentiate whether it is a case of hydronephrosis, putty kidney or a Staghorn calculi, the first thing that you have to do is to identify whether it is a X-ray KUB or it is a IVP beta. Here I am able to tell that it is a X-ray KUB. Why? Because if it was a IVP beta, I would have been able to see the contrast in the ureter also or in the bladder also. But neither the ureter nor the bladder is visible. That means there is no contrast. So it is a plain X-ray KUB beta. And on that X-ray KUB, if there are two options, if it is X-ray KUB, hydronephrosis has been ruled out because hydronephrosis is seen on IVP only. So now if it is X-ray KUB, there are two possibilities. Either it is a putty kidney or it is a Staghorn calculi. If on X-ray something appears white, that means it is a calcification or a stone beta. Here you are able to see the calcification in the form of kidney. When on X-ray KUB, the calcification is seen in the form of kidney, that has to be a putty kidney. And when on the X-ray KUB, the calcification is seen in the form of a renal pelvis beta, okay, in the shape of the pelvis, then it is a Staghorn calculi. Hopefully that's clear to all of you. Now, we discussed about renal tuberculosis beta. We know that putty kidney is a feature that is seen in patients of renal TB or renal tuberculosis. Renal TB which is there beta, it is not a primary TB, it is a secondary TB. That means the patient has a pulmonary TB beta, and from there via the blood route or via the hematogenous route, the TB or the infection spreads to the kidneys causing renal tuberculosis. Here definitely initially the earliest feature will be ulcers on the renal papilla. Initially there is ulceration at the renal papilla which may further develop into pus inside the kidneys, that is called as pyonephrosis. Later on definitely there will be fibrosis and calcification of the kidney called as putty kidney. Then the calcification of the kidneys will increase called as the cement kidney. Ultimately beta, the kidneys will be completely gone, completely damaged, called as autonephrectomy. Now we know autonephrectomy is a special feature beta seen in patients of renal tuberculosis. Can you tell me autosplenectomy is a feature of which condition? Autonephrectomy in renal TB. Autosplenectomy is seen in which condition? Which anemia? Sickle cell anemia beta. Do you remember that? Autosplenectomy is a feature of sickle cell anemia, whereas autonephrectomy is seen in case of renal tuberculosis. Do you remember? Now IVP when I do in patients of renal TB beta, I'll be able to see the moth-eaten chelicus. ठीक है, IVP पे definitely in renal TB I'll be able to see moth-eaten chelicus as if किसी कीड़े ने खाया हो chelicus को, right? Important feature, when I do a lab diagnosis in cases of renal TB beta, we send a urine microscopic examination. On that, what is the special feature? That you are able to see pus cells beta, but no bacteria as such. Okay, and that is what is called as sterile pyuria or sterile aciduria. Very classical. याद रखना, sterile pyuria or sterile aciduria is very very classical of renal tuberculosis or bladder tuberculosis. Do remember that. Okay, so do remember this term. And treatment, any TB anywhere beta, it has to be ATT, that is nothing else but anti-tubercular therapy. Okay, now that is important. Next, if I talk about beta, is this condition over here. What you are able to see here, you are able to see beta, the kidney that I've highlighted. In that there is enlargement of the kidney and there is collection of some there is some blackish appearance in the kidney. Why? Because there is collection of gas or collection of air inside the kidney. Okay, and the patient is having features of pyelonephritis or kidney infection. Now, when there is a kidney infection which leads to collection of gas, that is called as emphysematous pyelonephritis. We know the most common cause of emphysematous pyelonephritis is E. coli beta. Okay, and the treatment has to be antibiotics over here. Can anybody tell me what is the most common cause of emphysematous cholecystitis? When there is gas, when there is infection and gas formation inside the gallbladder. Most common cause of emphysematous cholecystitis. So do remember that beta, gas forming organism. Which one is that? The most common cause of emphysematous pyelonephritis is E. coli. It is also the most common cause of UTI as well. But most common cause of emphysematous cholecystitis beta, gallbladder metis, Clostridium perfringens. भूल गए क्या? Most common cause of emphysematous cholecystitis beta, it is Clostridium perfringens. Do remember that. Okay? So C for cholecystitis, C for Clostridium. Beta, Klebsiella does not form gas. It is Clostridium which forms gas. Okay? Cholecystitis के लिए it is Clostridium perfringens, but kidneys, pyelonephritis के लिए it is E. coli. Done? Next important beta, if they ask you about urolithiasis now. Urolithiasis is nothing else but stones inside the urinary tract beta. Okay, when I say stones in the urinary tract or urolithiasis, I mean nephrolithiasis, that is stones in the kidneys. Okay, that is your renal stones, as well as your cystolithiasis, that is stones in the urinary bladder beta. Okay, both the stones I'm talking about. Now, if they ask you beta, please tell me in the chat box which is the most common type of bladder stones in children. The most common type of urinary bladder stones in children. The most common type of urinary bladder stones in children. Anybody answer that? Do remember the most common type of urinary bladder stones in children are triple phosphate stones beta. Okay, it is triple phosphate stone. If they ask you most common type of urinary bladder stones in adults, the most common stones of most common urinary bladder stone in adults. Most common urinary bladder stones in adults. Is uric acid stones beta, ammonium urate. Okay, most common type of bladder stones in adults is the ammonium urate, that is uric acid stones beta. Next, if they ask you which is the most common type of renal stone, अब ये सबको पता होना चाहिए. Now I am talking about kidneys. Which is the most common type of renal stones beta? Very good. The most common type of renal stones are calcium oxalate stones. Shabash. The most common type of renal stones are calcium oxalate stones. We know calcium oxalate stones are made up of two types of crystals beta. Okay, they are made up of two types of crystals. One crystals are dumbbell shape. Which crystals of calcium oxalate are dumbbell shape beta? Monohydrate or dihydrate? Which crystals of calcium oxalate stones are dumbbell shape? Monohydrate or dihydrate? Monohydrate. Shabash. So please remember beta, the most common type of renal stones are calcium oxalate stones. Okay, dumbbell shaped crystals are seen in monohydrate calcium oxalate stones, and envelope shaped crystals are seen in dihydrate calcium oxalate stones beta. Dumbbell shaped crystals, envelope shaped crystals are seen in dihydrate calcium oxalate stones. We know, if I talk about which are the most common type of calcium oxalate stones, whether monohydrate or dihydrate, answer has to be dihydrate. Dihydrate calcium oxalate stones are much more common beta. Next, if they ask you beta, hexagonal shaped crystals or benzene ring shaped crystals. So hexagonal or benzene ring shaped crystals are seen in cystine stones beta. Okay? Hexagonal or a benzene ring shaped crystals are seen in cystine stones. And we know cystine stones are the hardest renal stones. Cystine stones are going to be the hardest renal stones. Next important, if they ask you, coffin lid shaped crystals. Coffin lid shaped crystals we know are seen in triple phosphate stones beta. Triple phosphate, why? Because they are made up of calcium phosphate, ammonium phosphate and magnesium phosphate. Therefore, okay, so coffin lid shaped crystals are seen in triple phosphate stones, and we know triple phosphate stones are also known as struvite stones beta. They are also called as struvite stones. We know that triple phosphate or struvite stones are usually formed in alkaline pH of urine, and there is one urinary tract infection which makes the pH alkaline and therefore increases the risk of triple phosphate stone. Repeated question of your exam. So that infection is nothing else but Proteus beta. So Proteus urinary tract infection increases the risk of triple phosphate stones or struvite stones in the patient. And last, irregular shaped crystals or universal crystals beta. Any shape, that means, okay, irregular shaped crystals or universal crystals are seen in uric acid stones. Uric acid stones are seen in patients suffering from hyperuricemia, that is nothing else but gout. Apart from gout, we know they also are seen in patients suffering from tumor lysis syndrome. So gout, tumor lysis syndrome or Lesch-Nyhan syndrome are the conditions where uric acid stones can be seen beta. No issues with this. So now important is if they ask you what is the first line investigation for a renal stone or for urolithiasis, do remember that 90% of the renal stones which are there beta or 90% of the urinary tract stones are radio opaque. That means which will appear white on X-ray and CT. Therefore, the first line investigation is the X-ray KUB, kidney ureter bladder, and on that you are able to see beta this kind of a stone. Now, if there is a stone beta which is so big in size, so giant in size, and it has taken the shape of the renal pelvis, we know it is called as Staghorn calculi. Can anybody tell me Staghorn calculi is actually which renal stone? Staghorn calculi is which renal stone? Whether it is cystine stone, calcium oxalate stone, triple phosphate stone, or uric acid stone. Staghorn calculi is actually which stone in the kidneys? Very good. Triple phosphate stone. Shabash. So triple phosphate stone, the struvite stones beta, when they grow very big in size and they take shape of renal pelvis, that is called a Staghorn calculi. Shabash. If they ask you investigation of choice for renal stones beta, do remember that investigation of choice for renal stones is the NCCT KUB beta. Okay, non-contrast CT scan of kidney, ureter and bladder. So investigation of choice is NCCT KUB, where you are able to see here the stone is present inside the kidney beta. Okay. If they ask you this one, now this one we know beta is nothing else but a giant bladder stone, because the stone which is there, it is seen exactly in the center of pelvis in the bladder. And second, it is a homogeneous calcification beta. The whole calcification appears uniform over here. So it is a giant bladder stone. If I say heterogeneous calcification is there beta, if I say heterogeneous calcification is there, then it is a case of, please tell me, heterogeneous calcification अगर दिख रहा है तो बोलो. If heterogeneous calcification is seen beta, please tell me, then it is a case of fibroid. Very good. Heterogeneous calcification, that is dots, white dots, if they are seen beta, then it is a case of a calcified fibroid beta, and that calcified fibroid will give us a classical womb stone appearance beta. That will give us a classical womb stone appearance. Shabash. Okay, now if they ask you beta what is the most common symptom, we know beta the most common symptom in cases of stones is nothing else but pain beta. If the stone is only inside the kidney, the patient will have lumbar pain beta. The stone is only in the kidney, the patient will have lumbar pain. And if the stone is anywhere in the ureter beta, please remember, if the stone is anywhere in the ureter, that will cause a radiating pain. Okay, in the kidneys only lumbar pain, but in ureter beta the patient will have a radiating pain. That is, for example, if the stone is in the upper 1/3 of the ureter beta, patient will have a lumbar pain which radiates to perineum in females or scrotum in males beta. The lumbar pain radiates to perineum in females or scrotum in males. It is at the level of upper 1/3 of the ureter. If the stone is at the pelvic brim beta, if the stone is at the level of the pelvic brim, then there is lumbar pain radiating to the inner thigh of the patient. Lumbar pain radiating to inner thigh. Next, if the patient is having a pain beta, lumbar pain radiating to the iliac fossa. If there is a lumbar pain radiating to iliac fossa, that means the stone is in the middle 1/3 of the ureter. Then the stone is in the middle 1/3 of the ureter. If the stone is in the lower 1/3 of the ureter beta, the stone is in the lower 1/3 of the ureter, then there is lumbar pain. Sorry, there is strangury beta. Lower 1/3 of ureter mein if there is a stone, that will lead to strangury. What is strangury? A painful desire to pass the urine beta. Okay. So whenever the patient will try to go for urine, the patient will have extreme pain beta. That is called as strangury, which is seen in lower 1/3 of the ureteric stone. Urinary bladder stone mein the patient will have suprapubic pain beta. Urinary bladder stone mein the patient has a suprapubic pain. And bladder neck or urethral stone beta, when the stone is at the level of the urinary bladder neck or at the urethra, then the patient will have a suprapubic vein radiating to the tip of the penis beta. Patient has a suprapubic vein radiating to the tip of the penis. Okay? Next important, if they ask you now, what is the treatment based on the location of the stone beta? Please tell me if the stone is in the kidney, upper or middle part of the ureter. Kidneys, upper ureter, middle ureter. If the stone is over here beta, first condition, when the stone is less than 5 to 6 millimeters in size, what is the treatment? In these three locations, if the stone is present and it is less than 5 to 6 in size, what is the management? Follow? It is less than 5 to 6 in size. Very good observation. Shabash. So please remember, if the stone is in these three locations beta, and if it is less than 5 to 6 millimeters in size, then only a conservative management observation is done beta. You can recommend the patient plenty of fluids, okay, and you can give syrup like alcohol beta. But if the stone is more than 5 to 6 millimeter in these three locations, if the stone is more than 5 to 6 millimeter, then we can go for a ESWL beta. And we know what is ESWL, this one, when there are shock waves directly fired onto the stone beta, which will break the stone into multiple pieces or fragments. Okay, this is what is definitely ESWL beta. Okay, so ESWL is extracorporeal shock wave lithotripsy, that is breaking down the stone into fragments. Okay, extracorporeal shock wave lithotripsy beta. And after ESWL beta, what happens is the patient has multiple fragments of the stone which try to come outside via the ureter, and therefore all these fragments of stones align themselves in the ureter. So that you should give a lot of fluids to the patient after ESWL, so that all these fragments of the stones are washed off from the urine. Bolo, what is this phenomena called as? Previous year question. After ESWL, when the fragments of the stone align themselves in the ureter for excretion, what is this phenomena called as? It is known as the Sten-Strasse phenomena. Very good. Yes, it is known as the Sten-Strasse phenomena beta. So when the fragments of the stone are in single line in the ureter beta, that is known as the Sten-Strasse phenomena. Shabash. That is important to be remembered. Now, if they say beta, if a stone is more than 2 centimeters in size, we know if the stone is more than 2 centimeters in size beta, it cannot be broken down by ESWL. There are certain contraindications of ESWL. First, if the female is pregnant. Second, if the patient is already suffering from some bleeding disorder. Third, if there is obstruction distal to the stone beta. Okay. Or fourth, if the stone is more than 2 centimeters in size. These are certain conditions where ESWL is contraindicated. Very good. In those conditions beta, what is the treatment then? If the stone is more than 2 centimeters in size, then it is classically called, then we classically go for a PCNL beta. And PCNL is nothing else but percutaneous nephrolithotomy. Shabash. It is nothing else but percutaneous nephrolithotomy beta. That has to be sure. That is important. Now, when the stone is in the lower part of the ureter beta, when the stone is in the lower part of ureter, we can go for a URS. What is URS? Ureteroscopic removal. Yes, we will pass a camera beta and we will pass a catheter beta, and with the help of that, we are going to remove the stone from the lower ureter. So lower ureteric stone we can go for a URS, ureteroscopic removal. And which basket is used for removal of the lower ureteric stone beta? Can you tell me the name of that basket? A ureteroscopic removal, which basket is used for the removal of stone? Dormia basket. Shabash. So during ureteroscopic removal beta, for the removal of stone, we are going to use the Dormia basket beta. Shabash. That has to be removed. Next, if there is a urinary bladder stone beta, for urinary bladder stone, we can go for a lithotripsy. That is again breaking down the stone into multiple pieces and letting those pieces flow out from the urine. So urinary bladder stone ke liye the treatment is lithotripsy. But if it is a large or a giant urinary bladder stone beta, large or giant urinary bladder stone may lithotripsy is not possible. In that condition, we have to remove the stone directly from the bladder, and that is called as cystolithotomy beta. That is known as cystolithotomy. And if the stone is in the urethra, we know beta, if the stone is in the urethra, we have to push back this stone into the urinary bladder and treat it like a bladder stone. Yes, if the stone is in the urethra, push it back into the bladder and treat like a bladder stone. Please tell me, if the stone is at the tip of the urethra or at the external urethral meatus, then what is your management? Are you going to push it all the way back into the bladder? No, right? So please tell me if the stone is at the tip of the urethra or the external urethral meatus. What is the management? Forceps removal. Very good. Just apply some lignocaine jelly beta and then go for a forceps removal if it is almost at the tip of the external urethral meatus. Shabash. Now, here they ask you beta, patient presents with abdominal mass, flank pain and hematuria. So this is a classical triad beta, mass, pain and hematuria. So abdominal mass, flank pain or lumbar pain and hematuria is a classical triad seen in a patient of RCC. What is RCC? Renal cell carcinoma beta. So if there is a cancer or a malignancy arising from the kidney, that is renal cell carcinoma beta. Now, can anybody tell me? We know that renal cell carcinoma is actually adenocarcinoma itself beta. So please tell me which is the most common subtype of renal cell carcinoma? Which is the most common subtype of renal cell carcinoma? Very good. Clear cell carcinoma beta. Shabash. So please remember the most common subtype of a renal cell carcinoma is a clear cell carcinoma. And can you tell me that this clear cell carcinoma of kidneys is associated with which gene mutation? The clear cell carcinoma of kidney is associated with which gene mutation beta? That is important as well. We know that there are multiple other types like the papillary renal cell carcinoma. In papillary renal cell cancer, the patient will have samoma bodies beta on histopath. Then we have the chromophobe type. Chromophobe type will have the plant cell like appearance beta, and that plant cell, the chromophobe type having plant cell like appearance will have the best prognosis among all types of RCC. And worst prognosis is usually seen with the Bellini duct carcinoma beta. Worst prognosis is seen with Bellini duct carcinoma. Shabash. Another PYQ that was you are rightly answered it. So please remember clear cell renal cell carcinoma is commonly associated with VHL gene mutation, that is von Hippel-Lindau gene beta. So von Hippel-Lindau gene, VHL gene mutation beta, chromosome number 3, shabash. It is definitely associated with clear cell RCC beta. Now important is if they ask you what is the most common symptom. See, triad is pain, mass and hematuria. But it is not the most common symptom. The most common symptom is usually initially it is increased frequency of urine and later on it is a painless hematuria. Okay? That is a very classical feature which is seen in patients of RCC beta. Investigation of choice, as you are able to see. I have told you definitely we do not take a biopsy in kidney cancers. Investigation of choice is a CECT abdomen, is a retroperitoneal organ. You can see the white arrows or the yellow arrows marking towards a mass which has started growing from the kidney beta, such a huge mass. Right? So investigation of choice is CECT abdomen. We know the treatment beta. If the tumor is less than 4 centimeters in size, we can go for a partial nephrectomy. Okay, so if tumor is less than 4 centimeters in size, we can just remove the tumor with some part of the kidney, that is partial nephrectomy. But if the tumor is more than 4 centimeters in size, we have to go for a radical nephrectomy. More than 4 centimeters size, radical nephrectomy has to be done. Now, please tell me in the chat box which is the most common renal malignancy in childhood. Most common kidney malignancy or renal malignancy in childhood. Follow. Very good. Wilms tumor, also called as nephroblastoma. Shabash. Most common renal malignancy or kidney malignancy in childhood is Wilms tumor, also known as nephroblastoma beta. But if they ask you, which is the most common abdominal malignancy in childhood beta? Which is the most common abdominal malignancy in childhood? Then what is your answer? Most common abdominal malignancy or cancer. Then it is neuroblastoma. Shabash. Please remember beta, if they ask you most common abdominal malignancy in childhood, then answer is neuroblastoma. तो याद रखना, most common abdominal malignancy in childhood is neuroblastoma, followed by the second most common is nephroblastoma or your Wilms tumor. ठीक है, तो abdomen की अगर बात हो तो neuroblastoma is most common, followed by nephroblastoma. ठीक है, we know that Wilms tumor or nephroblastoma is due to WT1 and WT2 gene mutation beta. It is commonly associated with syndromes like Dennis-Drash syndrome, Beckwith-Wiedemann syndrome beta, or Wagner syndrome. These are the conditions with which it is commonly associated. Investigation of choice, I told you for Wilms tumor, it has to be MRI abdomen beta. The only difference, okay, the only condition which is different, otherwise all retroperitoneal problems with a CCT abdomen except Wilms tumor where it is MRI abdomen. When I remove the mass and send it for histopathological examination on biopsy, on that histopath beta, I'll be able to see a very classical picture that is a mixed tumor. Wilms tumor is a mixed tumor beta. That means I'm able to see epithelial elements, blastomal elements, mesenchymal elements, everything is seen in mixture beta. That has to be remembered. Clear? In the early stages, okay, in cases of Wilms tumor beta, surgery and chemotherapy is enough. But in the later stages, surgery, chemo as well as radiotherapy is also required. Okay, so that has to be remembered. You remember this. Now answer this question out here. A 40-year-old man beta comes to the emergency room complaining of a sudden onset very severe pain in the left loin or in the left lumbar region of 4 hours duration, radiating to the front of the lumbar area and groin as well, and the left testis. He has vomited a couple of times and has a urinary frequency as well. Urinary frequency, that means he has to go again and again. On examination, he is writhing in pain and cannot find a comfortable position. What is the likely diagnosis? बोलो. ABCD कोच बोलो तो सही आंसर. चलो YD. YD. Answer is right. D. YD. One reason. I just now told you also when I was discussing about stone. See, it cannot be a subphrenic abscess, neither a pyonephrosis. Reason is whether it is a case of subphrenic abscess or pyonephrosis. Pyonephrosis is seen in renal TB. So both of these are definitely infections beta, and in both these conditions, the patient would have a history of any kind of fever. Along with pain, the patient may also have history of fever, the leukocytosis, inflammatory markers elevated, something like that. No, nothing is seen. So without that, I cannot make a diagnosis of infection directly. So A and B are ruled out beta. Very good. Next option C, which is there, it is nephrolithiasis, that is kidney stone or renal stone beta. I told you if there is only renal stone, the patient will have pain only in the lumbar region beta. It will not radiate. But yes, if the stone is in the ureter, if the calculi or the stone is in the ureter beta, then the pain is going to radiate. Very good. At multiple sites. If there is radiation of that lumbar pain, matlab it is a ureteric calculi. Answer D has to be your, the option D has to be your answer. Very good. Shabash. Answer this also. A 30-year-old male was investigated for infertility. Semen analysis reveals oligospermia. Biopsy image has been given below. What is the most probable diagnosis of the patient? So if you have read the question, I'll just zoom in for the picture. अब बोलो बोलो. A B C D. What is your answer? So the answer has to be option. So bolo, at least some A B C D you are going to answer na. Do not have any option to skip an FMG examination. Need PG mate, there is option to skip, not in your exam. Never take that chance skipping question. Very good. Yes, it is a case of Aortic stenosis arrhythmia. Yes, that is a classical case of testicular atrophy, beta. Shabash. Reason: the patient was infertile, beta, and when semen analysis was done, there was oligospermia. Oligospermia means there was decreased sperm count, beta, right? Oligospermia means less than 39 million sperms sorry, per ejaculate, right? So definitely oligospermia or decreased sperm count was there. Biopsy has been given below. On biopsy, what are you able to see? Are you able to see more number of cells or less number of cells? I am able to see less number of cells, beta. If more number of cells were there, definitely everything would have appeared blue, na? Seminoma mein, what is the picture that I've told you? There are a lot of cells, beta, with a prominent nucleus, so everything appears blue. Even in between the cells, there are fibrous strands, and in those fibrous strands also there are blue dots, which are suggestive of the lymphocytes which will be there. So seminoma mein or in a non-seminomatous tumor, in both the conditions, a lot of cells would be seen. Here rather I am seeing deficiency of cells, beta, right? Even in the seminiferous tubules, there are less number of cells. That means it is a case of testicular atrophy, bache. As it is a case of testicular atrophy, that is the reason the production of sperm is going to decrease, and that's the reason the patient is having oligospermia also. Okay? So this was a recent NEET PG question, so do remember these kind of questions. Orchitis is inflammation of the testis, beta, which can be seen as a complication in adolescent patients or mums. Okay? Over there, definitely I would have seen a lot of lymphocytic infiltrate, but not atrophy like features, right? We'll discuss bladder and urethral rupture in the TND part as well. Okay, so don't worry about that. I'll discuss that in the TND part. Now, ye bolo, a neonate was brought to the emergency room, beta, with urine retention, and the child was diagnosed with complete posterior urethral valve with MCU. Okay, MCU is micturating cystourethrogram, which is the investigation of choice for two conditions. One is a posterior urethral valve, and second is vesico-ureteric reflux. So, yaad rakhna, MCU, that is your micturating cystourethrogram, when we take the X-ray of the baby, beta, after injecting the contrast, when the child is urinating or micturating, that investigation is the MCU or micturating cystourethrogram. It is investigation of choice for two conditions. Again, I am repeating: posterior urethral valve and vesico-ureteric reflux. Now here, what is the emergency management in the child? Neonate brought to the emergency, urine retention hai, complete posterior urethral valve. In the posterior urethra or the prostatic urethra of this baby, beta, there is a complete valve which is not allowing the urine to come out. So what should be the management? The emergency management has to be, so it is insertion of a Foley's catheter, beta. Do remember, very good. Yes, insertion of the Foley's catheter has to be the emergency management. Reason is, as there is urine retention and the urine is not able to come out, beta, we have to insert a Foley's catheter from outside. So you will be like, sir, it is a complete valve now. Yes, it is a one-way valve, beta. It will not allow the urine to come outside, but it will allow the Foley's to enter. Therefore, the emergency management is Foley's catheterization, and definitive management is to remove this valve, beta. And removal of this valve is done by a surgery called as TURV, T-U-R-V, transurethral resection of valve or transurethral fulguration of valve, beta. That is the surgery with the help of which? With the help of laser, you are going to cut this valve, beta. That is called as a TURV, that is transurethral resection of valve. No issues with this, anybody? That has to be remembered. Now, important is, beta, if they ask you, here there is next question which says, a neonate was delivered preterm and on examination, his scrotal sacs appears to be empty, beta. So ultrasound was performed which reveals the right-sided testis is in the inguinal canal and the left one is in the iliac fossa. What is your likely diagnosis? Please tell me that. Options. Option A says both the testes are ectopic. Option B says both the testes are undescended. Option C says right is undescended, left is ectopic. And option D says right is ectopic and left is undescended. Very good. So here you are able to see, beta, this one is a classical case where the right sided testis is undescended and the left one is ectopic. Very good. The reason is, beta, what do I mean by undescended testis? हमें पता that testis are going to develop in the abdominal cavity, beta, and between 7 to 9 months of intrauterine life, these testes will come down into the scrotal sacs. That is called as descent of testis. Now, what is the normal pathway of descent from abdominal cavity via the inguinal canal into the scrotum, beta? This is the normal path of descent. Now, if the testis gets arrested in this normal path of descent, then it is called as an undescended testis. But we know, beta, that pelvis or the iliac fossa is not the normal path of descent. So if the testis is lying in the iliac fossa beta, it is an ectopic testis, right? So right-sided testis is in the inguinal canal. Matlab it has got arrested during the descent, and that is therefore right-sided testis is undescended. But left one is in the iliac fossa beta. Therefore, left one has to be ectopic in nature. This is a common repeated question of your exam. If they ask you about undescended testis beta, okay, undescended testis, please do remember, it can be seen on right side or left side. It can be unilateral, it can be bilateral beta. Bilateral undescended testis, when both the scrotal will be empty, and this condition is also called as cryptorchidism beta. Cryptorchidism means hidden testis. Okay? Most common cause of undescended testis, we know it is usually idiopathic beta. Most common cause of undescended testis is idiopathic. If they ask you what is the most important risk factor, then we know it is prematurity. That is, if the baby is born before 34 weeks period of gestation beta, that is prematurely, then definitely that is the most important risk factor for undescended testis. If they ask you what is the most common site, we know the most common site for undescended testis is the junction of the inguinal canal and the scrotal sac beta. So this is the inguinal canal, this is the scrotal sac. Just at the junction of the inguinal canal and scrotal sac over here beta, the testis will get arrested. Okay? Junction of inguinal canal and scrotal sac. Investigation of choice, if they ask you beta, we know the investigation of choice has to be ultrasound scrotum and ultrasound abdomen. Reason is, on ultrasound scrotum we will see that the testis is missing, so we have to search the testis in the abdomen at the same time. Okay? But if they ask you which is the gold standard or the best investigation, the best or the gold standard investigation for undescended testis is a laparoscopy beta. It is not practical though. Yeah, it is the best investigation overall, laparoscopy. Treatment of choice, if they ask you, it is nothing else but bring down the testis into the scrotum and fix it beta. That is called as orchidopexy. But if they say beta, a child has been brought to you at 3 months of age with undescended testis, what is your management? A child has been brought to you at 3 months of age with undescended testis, what is the likely management? Bolo? Child has been brought to you at 3 months of age with undescended testis. Very good. Now your answer has to be observation, reassurance, no treatment, conservative management, whatever you say. Okay, very good. So please remember beta, before 6 months of age we do not operate for a undescended testis. Reason is, in majority cases up to 6 months of age beta, the testis will come down on its own. Yes, majority cases mein up to 6 months beta, the testis will descend down on its own. Okay, so we have to wait for some time. So wait and watch, reassurance, observation, kuch bhi bolo, up to 6 months of age. The surgery can be done between 6 months till 18 months of age beta. Okay, the surgery can be done between 6 months till 18 months of age, and the best time is 9 to 12 months beta. Okay, so in this, what is the surgery? We have to bring down the testis and we have to fix the testis in the scrotum. That is called as orchidopexy bache. That is known as orchidopexy. Yeah, that is important. Next important is this condition. The first condition where you are not able to retract the prepuce or the foreskin. So if you are not able to pull back the foreskin or the prepuce from the glans penis beta, that is called as phimosis. Okay. So phimosis is you are not able to retract or bring back the prepuce or foreskin. That is phimosis. Usually it is physiological up to 6 years of age, but it can be pathological afterwards. And the most common cause for it is infection of the glans penis called as balanoposthitis beta. Treatment, if the patient is symptomatic, if the patient is having some problems due to phimosis, then we can go for excising or removal of the foreskin or the prepuce beta called as circumcision. So phimosis ke all symptomatic patients mein the treatment is circumcision beta. Next is paraphimosis. If I talk about paraphimosis, bache, do remember that here we have retracted the foreskin, we have brought back the foreskin. You are not able to bring it back onto the glans penis beta. Yes. So you have retracted the foreskin, but due to swelling, you are not able to bring it back onto the glans penis beta. This is called as paraphimosis. Here definitely the first line management has to be insert a Foley's catheter. Because of that swelling, the patient is not able to pass urine beta, there is urine retention. Therefore, first step is insert Foley's, drain the bladder. Second step is apply some lignocaine jelly and try to reduce. Even after application of jelly and reduction beta, till it fails, then we can go for a dorsal slit operation beta. Clear? Next one. What is this condition beta? We know that the urethral opening should be exactly in front of the penis. But here you are not able to see the urethral opening exactly in front beta. Rather it is seen on the downside, on the ventral side of the penis. And if the a urethral opening is on the ventral part of the penis beta, or the down part of the penis, it is called as which urethral anomaly it is? Rather, this is the most common congenital anomaly of male urethra. And what is this condition called as? When the urethral opening is on the ventral part of the penis. Hypospadia, shabash. So this congenital urethral anomaly is known as hypospadias beta. And अगर मैं पूछता हूँ कि which is the most common type of hypospadias, you are able to see so many types. Please tell me which is the most common type of hypospadias. Most common type of hypospadias beta. Not the coronal one beta. I've told you the most common type of hypospadias is the granular hypospadias beta, and therefore the most of the patients are even asymptomatic. They do not have any problem as such. The most common type of hypospadias is granular hypospadias, where it's just below the normal opening beta. Okay? The most common type is granular hypospadias, and that is the least severe, no symptoms as such. But the most severe and the least common, the most severe form and the least common is the perennial hypospadias. Perennial is the most severe beta, but the least common, thankfully. Okay? Now here the patient may have problems with urination, patient may have problems with deposition of sperms, therefore can be infertile as well beta. And the classical symptom, patient will tell that the urine falls on his feet or on his shoes itself beta. Okay? Urine falls on his feet or on his shoes. Treatment we know beta, we have to repair the urethra, that is called as urethroplasty, and we have to make opening exactly in the front. So now urethroplasty ke liye beta, we need the foreskin or the prepuce. So as we need foreskin or prepuce for repair of the urethra beta during urethroplasty, please tell me which is contraindicated. Oh, sorry, what surgical procedure is contraindicated in the child? As you will need the foreskin or the prepuce for the purpose of urethroplasty, which surgical procedure is contraindicated in a patient suffering from hypospadias? Very good. Circumcision. Yes, removal of the foreskin or removal of the prepuce, known as circumcision, is absolutely contraindicated in a child suffering from hypospadias, because if you remove the foreskin, you will not have any foreskin for the repair of urethra beta later on. Okay, that is important. Shabash. Next is priapism beta. What is priapism? It is a painful, persistent penile erection beta. If the patient has a penile erection lasting for a long time and it is becoming painful, it is causing swelling of the penis as well beta, that is called as priapism. Can you tell me, previous year question was a timeline. Painful penile erection lasting for how many hours is called as priapism beta. Lasting for how many hours is known as priapism. We know the most common cause of priapism is idiopathic beta, unknown cause. But secondary cause of priapism can be trauma. It is trauma due to violent sexual intercourse. So trauma due to violent sexual intercourse is the most common secondary cause. It can also be due to overdose of sildenafil in the patient as well beta. Very good. So priapism is a painful, persistent penile erection lasting for more than 4 hours. Shabash. That is important. If they ask you what is the most common cause of priapism in children, recent NEET PG question, answer. Most common cause of priapism in children. Most common cause of priapism in children. Most common cause of priapism in children. Sickle cell anemia. Shabash. So we know beta in sickle cell anemia, those sickled RBCs may cause blockage of the penile vessels, and that leads to collection of blood in the penis itself, leading to priapism in a child. Very good. Even leukemias can be a cause, but more common is definitely sickle cell anemia beta. Okay? Treatment, if they ask you whatever blood is collected in the penis, we have to aspirate that, we have to remove that blood beta. So treatment is aspiration of blood from the corpora cavernosa. So aspiration of blood from corpora cavernosa is the treatment done for priapism in the patient. Very good. Next, this is the condition beta, where when the penis is flaccid beta, the penis is absolutely normal. But as soon as the patient gets an erection, there is a curvature which is seen. Yes. When the penis is flaccid, it is absolutely normal, it is straight. But whenever the patient gets a curvature beta, whenever the patient gets an erection beta, the penis gets curved. So flaccid penis is normal, but a curved erection. What is this disease called as? This curvature is actually seen because of a fibrous plaque which is formed in one or both the corpora cavernosa beta, and therefore whenever a patient gets an erection, the penis gets pulled towards the side of the fibrous plaque. Very good. Peyronie's disease, beta. Shabash. So curve direction is seen in patients of Peyronie's disease. And we know what is the treatment in a patient of Peyronie's disease, beta? If a patient has come to me with Peyronie's disease for the very first time, what is the treatment? What is the first line management? Very good. So first line management has to be reassurance with our observation. Reason is we know, yeah, this was a PYQ to remember that. Okay. So first line management in a case of Peyronie's disease is definitely reassurance or observation beta. Okay. Because we know that Peyronie's disease is a self-limiting condition, it will get resolved within a span of 3 to 5 years. But yes, even after 5 years it doesn't resolve beta, then we may go for a surgery. Okay. Or if the patient is having problem, for example, the patient wants to get married the next year beta, then you cannot wait for 5 years. Then you have to go for immediate surgery. Okay, so if the patient is having problems, or if definitely 5 years have surpassed, then we have to go for surgery. And what is that surgery? Well, I place a non-absorbable suture in the opposite corpora cavernosa so that it is balanced out. Matlab, on one side the plaque is going to pull the penis, on other side our suture is going to pull the penis. So ultimately the penis remains straight. What is that operation called as? Shabash, very good. This is known as the Nesbitt's operation, beta. So Nesbitt's operation or Nesbitt surgery is the treatment done for Peyronie's disease, beta, that has to be removed. Next condition, this is also a proliferative growth seen in penile cancer, beta. We know that penile cancer is a squamous cell carcinoma also associated with HPV, human papilloma virus 16 and 18 infection. Okay, most common site for a penile cancer, as you are able to see, is the glans penis and the covering over it, that is your prepuce. The most common site for a penile cancer is the glans penis and the prepuce together. Okay, if you have to choose one, answer is glans penis. Patient may have ulceroproliferative growth. Along with that, a foul smelling discharge from the patient, from the penis, beta. Most common cause of death in penile cancer is torrential hemorrhage, excessive bleeding, which may cause even death of the patient, beta. Clear? Investigation of choice, as you can see, easily you can take a biopsy, beta. Treatment. If after cutting the penis, beta, we have to take 1 to 2 centimeter margins. But if after cutting the penis, if more than 2 centimeters of a penis is left, even after cutting the penis, if more than 2 centimeters of the penis can be left, then we go for a partial penectomy. But if after cutting the penis, less than 2 centimeters of penis is left, beta. If after cutting the penis, only less than 2 centimeters of the penis would be left. So it's better to go for a total penectomy. Okay? So that is important. Yes, poor hygiene is the most common cause of penile cancer, beta. Now this is a condition when a child has been brought to me with collection of fluid inside the scrotal sac, beta. The child comes to me with the scrotal swelling. Okay? When I flash a torch light, the whole swelling glows with light, beta. That is called as the trans illumination test. So the trans illumination test is positive in this child, bachche. Okay? Because there is clear fluid collected inside the scrotal sac. What is the likely diagnosis? Very good. This is a classical case of a hydrocele, beta. That is collection of fluid inside the scrotal sac, known as hydrocele. And we know there are 4 swellings in the body which are going to show brilliant positive trans illumination, beta. One in the scrotum is hydrocele. Another in the floor of mouth is the ranula. Third in the neck, in the posterior triangle of neck, is a cystic hygroma. And fourth in the lower back of a neonate is a meningocele, beta. These are the brilliantly transilluminant swellings. Okay? We know that these are the 4 types of hydrocele, beta. You can see the gray color now. That gray color is the fluid collection. In first one, you are able to see the fluid collection is only limited up to the scrotum. So this is the most common type of hydrocele, known as the vaginal hydrocele, beta. The first one is the most common type of hydrocele, known as vaginal hydrocele. Second way, there is inguinoscrotal swelling, beta. Yes, collection of fluid in the scrotum as well as the inguinal region. So inguinoscrotal swelling is seen in an infantile hydrocele. The second one is the infantile hydrocele, beta. Third one, you are able to see the fluid collection in the scrotum, in the inguinal canal, even in the abdomen. So there is a complete connection, beta, which is still there. This is called as a congenital hydrocele. The third type is a congenital hydrocele, beta. And fourth type, only in some part of the cord, beta, you are able to see a fluid collection. This is called as an encysted hydrocele. Encysted hydrocele. Most common cause of hydrocele overall is again idiopathic, but most common secondary cause, if they ask you, it is infections. And what is the most common infection, anybody? Most common cause overall for hydrocele is idiopathic, but most common secondary cause are infections. It can also occur due to trauma and malignancy. But please tell me, which is the most common infection causing hydrocele? Most common infection which can lead to hydrocele. Filariasis, shabash. So we know that lymphatic filariasis or a Bancroftian filariasis caused by Wucheria bancrofti beta, that is a cause for a hydrocele, secondary cause for a hydrocele, has to be remembered. Okay? Now in this patient, the patient will come to you with a painless scrotal swelling or a painless inguinoscrotal swelling beta. Trans-elimination test will be done, which is positive. Investigation of choice is ultrasound scrotum, because fluid collection is there now. So investigation of choice is ultrasound scrotum. And treatment now. Please tell me if it is, okay, please tell me if it is a small hydrocele beta, I can just open up the sac, I can drain the fluid, and I can plicate the margins, or I can ligate the margins on the sides. Okay, this is called as which surgery? If it is a small hydrocele, you can drain and ligate the margins on the sides, called as which surgery beta? It is known as the Lord's plication surgery. It is known as the Lord's plication surgery. If it is a larger hydrocele, in larger hydrocele beta, I have to open up the sac, I have to drain all the fluid. Then after that, I have to evert the sac beta. Ulta karna sac ko. I have to evert the sac, and after eversion of sac, I have to suture it back, so that there is no chance of collection only. Okay. So open the sac, drain the fluid, evert the sac, and suture it back. That is called as which one? That drainage and eversion is known as Jaboulet's surgery. Very good. That for a larger hydrocele, the best surgery is the Jaboulet surgery. Okay, and please tell me for congenital hydrocele, what is the treatment? Congenital hydrocele, what is the treatment? Congenital hydrocele, what is the treatment? Anybody? In this photo, mein wahi bol raha hu. This is a case of a congenital hydrocele beta. This is a picture of a congenital hydrocele, because it is an infant who has been brought to you with hydrocele. What is the treatment for this one now? We just have to open the sac and drain the fluid. Neither plication nor a neither plication sorry, nor a eversion. That is herniatomy beta. Very good. So herniatomy is what? Just make an incision on the sac and drain all the fluid. Bas itna hi karna hai. ठीक है? So if I just drain the fluid with that, that is called as herniatomy. We know herniatomy is the surgery of choice for congenital hydrocele as well as congenital hernia. Congenital hernia के लिए भी और congenital hydrocele के लिए भी the surgery of choice is same, herniatomy. Do remember beta that herniatomy is done immediately in cases of congenital hydrocele, but after 3 years in a patient of congenital hernia. Don't get confused. ठीक है? For congenital hydrocele you can go immediate surgery के लिए, और congenital hernia it is done after 3 years of age. That is important. Next is a question beta which states a 15-year-old male adolescent patient presents to you with a sudden severe scrotal pain and abdominal pain. On elevating the scrotum beta, the pain of the patient is not relieved. What is the likely diagnosis? Make a diagnosis of this case. What is the likely diagnosis? Torsion. Very good. This is a classical case of a testicular torsion beta that we have to remember. Do remember that. We know that it is a case of torsion. Why? Because we have done a clinical test. What is this clinical test which has been done beta? We know because testicular torsion and infection of testis known as epididymoorchitis, both are going to present to us with similar features, that is scrotal pain, abdominal pain, low grade fever, redness and other signs of inflammation on the testis. Same features, right? So please tell me what is the test? Very good. French test beta. On French test, we know when we elevate the scrotum or when we support the scrotum beta, if the pain of the patient gets relieved, after supporting the scrotum, if the pain of the patient gets relieved, that means it is a case of inflammation, that is epididymoorchitis. But even on elevating the scrotum beta, the pain is not relieved, or rather the pain worsens, then it is a case of testicular torsion. What is testicular torsion? When there is twisting of the spermatic cord or twisting of the testis beta. The twisting of the spermatic cord or twisting of testis is what is known as testicular torsion, due to which the blood supply to the testis is decreased and it may undergo necrosis beta. Okay, that is important. Now the important reason why a testicular torsion develops in the patient is a bell clapper deformity. When the testis is hanging like the clapper of a bell beta in that scrotum. Okay, so bell clapper deformity is the most important risk factor for testicular torsion. Investigation of choice, we know it is an ultrasound scrotum itself. If they ask you about the treatment, now treatment के तौर पे, if the patient presents to us early beta within 6 hours of symptom onset, if the patient has presented to us early within 6 hours of symptom onset beta, that means we can save the testis. The testis is still viable. It has not undergone necrosis. What we do, we derotate the testis and we fix the testis beta. So if the patient presents to us early within 6 hours of symptom onset, We derotate the testis and we go for an orchidopexy. Whereas if the patient presents to you late, usually after 12 hours, then the necrosis of the testis has happened beta. That means it is a non-viable testis now. And if the testis is non-viable, we have to remove the testis. That is called as orchidectomy. Removal of testis, orchidectomy. Now please tell me, if you are going to do orchidopexy or orchidectomy, whatever it is, are you going to treat the opposite side also at the same time? Are you also going to perform an orchidopexy on the contralateral or the opposite side in the same surgery itself? Yes. Do remember, whether you go for orchidopexy or the orchidectomy on the affected side, even try to fix the other sided testis beta. That is a contralateral orchidopexy is a must in the same surgery. Okay, shabash. Next important is varicocele beta. We know varicocele is what? When there is dilatation of the testicular veins. And what are these testicular veins called as? This is a special network called as pampiniform plexus of veins. So when there is abnormal dilatation and tortuosity of these pampiniform plexus of veins beta in the testis is called as varicocele. Now what happens as the testicular veins are dilated over here, a lot of blood collects in these testicular veins beta. There is pooling of blood in the testicular veins that makes the testis heavy, and due to that the patient may experience pain, the patient may experience heaviness, the patient may experience dragging sensation in the scrotum beta. And due to that dragging sensation, heaviness or pain in the scrotum, okay, the patient will always have a discomfort. Okay, that is a case of varicocele beta. Most common cause of varicocele is again idiopathic. Okay, most common cause of varicocele is again idiopathic. Please tell me, varicocele is more commonly seen on which side, right side or left side? Varicocele is more commonly seen on right side or left side beta? Hello? It is commonly seen on the left side beta. Reason, understand? Yes, very good. Varicocele is commonly seen on the left side beta. Reason is, please remember that the left testicular vein which is there beta, it drains like this into the renal vein. Okay? Exactly perpendicular or at 90 degrees. As the left testicular vein directly drains like this beta, it is not able to empty its blood properly into the renal vein. That's the reason a lot of blood collects in the left testicular veins beta, and that leads to varicocele more commonly on the left side. Yaad rakhna, it is more commonly on the left side. If I palpate, as you have rightly said, when you palpate, these dilated veins will feel like worms beta. So that will give you a very classical feel, that is a bag of worm feel will be there. Investigation of choice bolo jaldi. It is due to dilatation of vessels. याद रखना है बात. अब बोलो investigation of choice. Very good. Color Doppler. Investigation of choice is a color Doppler beta. And if I talk about treatment, the first treatment is angioembolization beta. First line management is angioembolization. Block the vessel so that the blood does not pool up over there, does not collect over there. Yeah? So first treatment, a first line management is angioembolization. If not, if that fails, then we have to go for surgical ligation of these veins beta, and that surgical ligation is called as a varicocelectomy. That surgical ligation is known as a varicocelectomy. Even sclerotherapy is tried in some cases, but it is not safer as of now. So nowadays, angioembolization followed by surgical ligation known as varicocelectomy are the choices. Even sclerotherapy is done. ऐसा नहीं है कि बंद है, but yeah, more commonly these are the ones. If they ask you which is the most common testicular tumor beta in children, the most common testicular tumor in children, answer is most common testicular tumor in children is yolk sac tumor beta. Shabash. Okay, most common testicular tumor in children is a yolk sac tumor. What is the tumor marker for yolk sac tumor? Whether it is surgery or gynae beta. Please tell me, what is the tumor marker for yolk sac tumor? AFP, shabash. Alpha fetoprotein is the tumor marker for a yolk sac tumor beta. Shabash. Next, if they ask you the most common testicular tumor overall or the most common testicular tumor in adults, the answer is same, seminoma. The most common testicular tumor in adults beta, we know it is seminoma followed by teratoma beta. Important is seminomas are of two types beta, classical seminoma or a non-classical seminoma. Please tell me, classical seminomas, I have told you cells with prominent nucleus in between fibrous strands with a lot of lymphocytes in it. Okay? Please tell me, classical seminomas are AFP positive or AFP negative? Classical seminomas के लिए, do we use alpha fetoprotein as a tumor marker? Yes or no? Like classical seminomas are AFP positive or AFP negative? Very good. That is important. Classical seminomas are AFP negative. Non-classical seminomas can be AFP positive beta, but classical seminomas are AFP negative. For classical seminoma, the tumor marker is not alpha fetoprotein. For them, it is LDH, lactate dehydrogenase beta. So classical seminomas ka tumor marker is LDH. Do remember this properly. Okay? That has to be remembered. Then if they ask you most common testicular tumor in elderly patient, it is lymphoma beta. Most common testicular tumor in elderly patient is a lymphoma, and most common bilateral testicular tumor is also a lymphoma. Most common bilateral testicular tumor is also lymphoma. Investigation of choice we know beta. Okay, please remember here the patient will come to you with a complaint of painless testicular mass. Trans-elimination test will be negative. Reason here there is not fluid collection but rather mass beta or tissue. That is the reason the trans-elimination test is negative in testicular tumor. Investigation of choice is a ultrasound scrotum beta. Yes. The investigation of choice is the ultrasound scrotum. Please remember, transscrotal FNSE or a biopsy is absolutely contraindicated because it may lead to risk of spread beta. That is the reason transscrotal biopsy or a FNSE is absolutely contraindicated. Treatment is a high inguinal orchidectomy beta, removal of the testis. Now, two important conditions of prostate. One is BPH beta. If they ask you about BPH, that is benign prostatic hyperplasia. There is increase in the number of prostate cells and therefore there is increase in the size of prostate. As the size of prostate increases, it causes compression of the prostatic urethra, leading to difficulty in urination in a patient beta. We know BPH is going to be more common in elderly males, usually more than 50 years of age. Please tell me, BPH is most common. What is the most common site for BPH beta? What is the most common site for BPH? The central zone, the transitional zone, or the peripheral zone? Which zone of prostate is the most common site of BPH, benign prostatic hyperplasia? Very good. It is the transitional zone. The transitional zone of the prostate which is there, it is the most common site of BPH in the patient. Shabash. Now if they ask you what is the drug of choice in cases of BPH beta? What is the drug of choice in cases of BPH? Mild to moderate BPH can be treated by medical management and the drug of choice is so. No, it is not 5-alpha reductase inhibitor. I have told you 5-alpha reductase inhibitors like finasteride cannot be the drug of choice because they definitely decrease the size of prostate, but they take 3 months for its action beta, and that cannot be a drug of choice. Okay. Yes, that is the effective drug, but not the drug of choice. Drug of choice is the one which will just dilate the prostatic urethra and improve the urine outflow of the patient because patient's main concern is that. Okay. So drug of choice has to be selective alpha 1A blockers beta, and these selective alpha 1A blockers are drugs like tamsulosin or silodosin. Do remember that. Along with that, you can give finasteride. Drug of choice is tamsulosin or silodosin like drugs. But we know beta that if I talk about a patient of BPH along with hypertension, if there is a patient of BPH along with hypertension, then what can be the drug of choice? BPH in a normotensive individual, tamsulosin. BPH in a hypertensive individual, then we will just give alpha 1 blockers beta, not selective ones. Then we will give alpha 1 blockers. Very good. Drugs like prazosin, terazosin, alfuzosin, because they also help in decreasing the BP of the patient. Shabash. So if there is a BPH in hypertensive individual, then the drug of choice are alpha 1 blockers only, drugs like prazosin, alfuzosin. Very good. Next important, if they ask you beta, if the patient is having severe BPH beta or there are complications of BPH, then we can definitely go for a surgery called as TURP beta. TURP is what? Transurethral resection of prostate. Will go inside the urethra with the help of laser. You will try to reduce the size of prostate beta. That is TURP, transurethral resection of prostate beta. Shabash. If they ask you prostate cancer, we know beta prostate cancer. What is the most common site of prostate cancer? Central, transitional, peripheral zone. prostate cancer is the most common cancer in elderly males, beta. Okay, overall. We know with most common cancer in males worldwide, it is lung cancer. Most common cancer in Indian males is oral cavity cancer. But most common cancer in elderly males worldwide also and in India also, it is prostate cancer, beta. Most common cancer in elderly males, it is prostate cancer. Most common site, very good, it is the peripheral zone for a prostate cancer. I have told you PPP. P for prostate cancer, P for peripheral zone, and P for the posterior lobe, beta. Screening is done by two things, beta. One is DRE, that is a digital rectal examination, which will like tell you about the enlarged prostate. And second, along with that, we have to check the tumor marker. All of us are quite aware the tumor marker of prostate cancer is serum PSA, beta, prostate specific antigen. So DRE plus serum PSA is the best screening test done for prostate cancer, beta. Okay, investigation of choice, if they ask you, your answer has to be, do remember, transrectal ultrasound guided biopsy, beta. So transrectal ultrasound guided biopsy is the investigation of choice for prostate cancer, beta. And the treatment, if they ask you, so do remember the treatment, if the patient comes to us in the early stages of prostate cancer. So early stages of prostate cancer mein the treatment is a radical prostatectomy, that is removal of the prostate along with the obturator lymph nodes, beta. But if the patient comes to us in the advanced stages of prostate cancer, advanced matlab when the cancer has already spread to the other organs, okay? So when the patient comes to us in the advanced stages of prostate cancer, then I can either go for brachytherapy, beta. What is brachytherapy? I will use radioactive iodine, beta, for killing these cancerous cells. Which radioactive iodine is used for brachytherapy in prostate cancer? Which radioactive form of iodine is used for brachytherapy in prostate cancer? Previous year question of your exam. Very good. Iodine 125. So it is iodine 125 which is used, beta. Shabash. Second important, if they ask you, we can also use hormonal therapy, beta, in prostate cancer because it is a hormone dependent cancer. And hormonal therapy mein we can use GnRH analogs or GnRH agonists, beta. Drugs like nafarelin, goserelin, or okay, or the relins. But they should be given in a continuous manner or a pulsatile manner. GnRH agonist or GnRH analogs can be used for hormonal therapy in prostate cancer, but they are given in a continuous manner or a pulsatile manner. Very good. They should be given in a continuous manner, beta. Then only they will cause suppression or desensitization of receptor. Okay? So they should be given in a continuous manner. Shabash. And lastly, if they say elderly male coming to you with low backache, the first thing should come to your mind is multiple myeloma. But if they say elderly patient coming to you, elderly male coming to you especially with low backache and urinary symptoms, then the first thing that should come to your mind is an advanced or a metastatic prostate cancer, beta. And advanced or metastatic prostate cancer mein why there is low backache? Because the most common site of distant metastasis in prostate cancer is the lumbar vertebrae. And we know usually whenever there is bony metastasis from any cancer, beta, it is more commonly bone breaking or osteolytic metastasis. But if they ask you which is the most common cancer causing osteoblastic or a bone forming metastasis, we know answer is prostate cancer. So here you can see definitely, beta, there is prostate cancer which is there. Please remember that the most common, okay, the most common cancer causing a bone forming or osteoblastic metastasis is the prostate cancer, beta. And it occurs, the spread occurs via the valveless veins known as the okay, known as the Batterson's plexus of veins, beta. Okay, Batterson's plexus of veins. No, breaking is osteolytic, beta. Forming is osteoblastic. So please remember, prostate cancer causes a bone forming or osteoblastic metastasis. No issues with this, anybody? Do remember this. Hernia I'll discuss in the questions itself. So properly hum hernia discuss kar payenge because I do not have pencils. I cannot access it. So bladder rupture, urethral rupture, and hernia. These are the points that I'll discuss over there. Ye bata do. What is this? This is a small one. Yes, osteolytic is more common in breast. Osteoblastic is more common in prostate cancer. This is a cystogram, and here the shape of the bladder you see, definitely it is somewhat different. How the shape of the bladder looks like. How the shape of the bladder is looking like, beta. It is not a case of bladder rupture. Yes, here there is a Christmas tree or a fir tree appearance of the urinary bladder. And we know Christmas tree bladder or a fir tree bladder is usually seen, beta, when there is retention of urine in the bladder. Why? Because the detrusor muscles of the urinary bladder are not able to contract. That means it is a case of an atonic bladder or a neurogenic bladder, beta. This is a classical picture of a neurogenic or an atonic bladder. What is the drug of choice for neurogenic or an atonic bladder? Drug of choice for a neurogenic or an atonic bladder. Hello? Bithanicol. I've told you the drug of choice for atonic or a neurogenic bladder is bithanicol, beta. Whereas the drug of choice for overactive bladder, completely opposite to this. Overactive means the bladder is contracting continuously. Drug of choice for overactive bladder is mirabegron. Okay, it is mirabegron. Next important is this, beta. Here you are able to see a narrowed contracted fibrosed urinary bladder. So narrow contracted fibrosed urinary bladder due to an infection, beta, called as thimble bladder is a feature of this narrow contracted fibrosed urinary bladder. It is due to infection of the urinary bladder. This is a feature of TB. Very good. So bladder tuberculosis, which is there, beta, will lead to this complication known as the thimble bladder, where there is narrowing, contraction, and fibrosis of the urinary bladder, beta. That is important to remember. This is the Foley's catheter that you can see over here. Baki I'll discuss over there itself. Now let's take a small break, and after break, beta, let's try to discuss few more points. So vascular also I discuss it in the questions itself. It will be easier for you to understand vascular surgery there. Vascular surgery, hernia, these are the two small topics I'll discuss. Class, this will be the last session after this, and in that last session I'll try to cover some important points which I'll not take in the questions then, so that I'll cover over here itself. Trauma, I think I'll cover it in the questions. Reason is trauma may now definitely if I ask you questions, yeah, I'll include trauma in TND. Reason is I'm telling you why. The important is trauma ki questions are somewhat complex. If I talk about trauma right now directly, like revision now, you'll be able to answer most of the time. Problem is when trauma comes in questions, now it becomes twisted. First line definitive, that becomes challenging. That you are not able to understand. उसमें गलती होती है. So trauma, I'll definitely cover it in TND itself because now you will answer me. But more important is the type of questions which come from trauma. So trauma, hernia, these are the confusing things that we will cover it over there itself. Okay, let's try to cover burns, breast, and thyroid. Okay, let's take a small break. Let's cover the easy topics which you already know: burns, breast, and thyroid. वैसे breast I'll also cover in TND as well. Yeah, let's cover burns, breast, and thyroid after this. Rest of the topic we'll discuss. Yeah, a small break, 15-20 minutes, and then we'll start. Up to 7-7:15 maximum the class would be, not beyond that. Good evening, everyone. Hopefully, all of you are back, and let's start with the discussion further. Shall we continue if the audio visuals are clear? Okay, chalo. So now, if I talk about burns, beta, please tell me which are the most common type of burns overall. We know that burns can be of two types, beta. If they are due to higher temperature, those are definitely called as the thermal burns, beta. Whereas if they are due to lower temperatures, they are called as a cold burns, beta. We know definitely overall more common are thermal burns. Now, thermal burns are also of two types, beta. Thermal burns are also of two types. If they are directly due to the flame of beta, they are known as flame burns, and if they are due to steam, those are steam burns. Okay? So thermal burns can also be of two types. Either they can be flame burns or steam burns. What do you think? Which are the most common type of burns overall? So the most common type of burns overall are the steam burns, beta. Okay, the most common type of burns overall are the steam burns, and in steam burns, beta, the day-to-day burns that we get usually due to some hot liquids like hot milk or hot water are called as these first degree steam burns are known as scalds, beta. So most common burns overall, if they ask you, answer is steam burns, and in steam burns, if they ask you which ones, the answer is scalds, which is due to hot liquids, beta. Next, if they ask you that which are the most common type of hospital burns, then because steam burns or scald wala patients does not come to us in the hospital majority times, right? So if they ask you which are the most common type of hospital burns, then what is your answer? Who come to us in the hospital? The most common type of hospital burns are going to be flame burns. Very good. The most common type of hospital burns are going to be flame burns, beta, जो आग में झुलस जाते हैं वो लोग. ठीक है. Most common type of cold burns. Now cold burns are of two types, beta. Either if it is due to freezing temperature, it is known as the frostbite. If it is due to sub-freezing temperature, it is known as a trench foot. So what do you think is the most common type of a cold burn? Frostbite or trench foot? Most common type of cold burns are the frostbites, beta. Very good. The most common type of cold burns are frostbite. Very good. Due to freezing temperature. Okay. Now, if they ask you the three mechanisms of injury or death in a case of burns, beta. If they ask you which is the most common immediate cause of death, beta. Which is the most common cause of immediate death after burns? Usually immediate death matlab within few hours after burns, beta, the patient dies. The most common cause of immediate death in a case of burns has to be most common cause of immediate death in a case of burns has to be asphyxia. Very good. So asphyxia or suffocation, hypoxia, whatever you call it, beta. Okay, so asphyxia, suffocation, hypoxia, whatever it is the most common cause of immediate death in a case of burns within few hours, beta. Reason is if the patient is going to have asphyxia, beta, the patient may die due to respiratory arrest, right? Asphyxia or hypoxia is more common when we are going to suspect any kind of inhalational burns in the patient. Now, what are the cases of inhalational burns? So we know definitely if the patient is having any burns in the face or the neck region, beta, or if there is any burning or signing of nasal hairs, beta, or if the patient has been trapped in a closed burning room, because then the patient is going to inhale those soot particles, beta, or if the patient is having black or carbon deposits in the sputum, okay, or definitely the patient who is there, beta, he is having hoarseness of voice. Okay, so all of these are hints towards inhalational burns, beta. First thing. Second important thing, if I talk about, beta, is please do remember that when a patient is having any kind of burns which is involving the face and neck, as I told you, definitely, okay, or any patient who has inhaled the soot particles, because due to inhalation of soot particles there is inflammation of the airway and there is narrowing of the airway, beta. Second, definitely the patient may also have alveolar edema due to inflammation, beta. That may also be a cause of hypoxia. Okay, so do remember that. So most common cause of immediate death in a case of burns is definitely asphyxia, beta. Next, if they ask you the second most common cause of immediate death in a case of burns, that is immediate death, they have asked you, but asphyxia is not an option. The second best answer has to be neurogenic shock, beta. Due to severe pain, the patient lands up into neurogenic shock, and that can also be a cause of immediate death in a case of burns. If they ask you most common cause of early death in a patient, a case of burns, early death matlab within the first 1 to 2 days, beta. So within 1 to 2 days after the burns, if the patient dies, the most common cause of early death has to be hypovolemic shock, beta. Reason is we know due to burns there will be excessive blood loss, there will be severe dehydration in the patient, so the patient may land up into hypovolemic shock. And that's the reason the first 24 hours are considered to be the most crucial period beta for a patient of burns. Reason is we give a lot of fluid resuscitation during the first 24 hours to prevent our patient from hypovolemic shock. Next, if they ask you most common cause of late death in a patient of burns beta, late death matlab after 3 to 5 days. Most common cause of late death after 3 to 5 days in a case of burns. What is the cause? Most common cause of late death in a patient of burns after 3 to 5 days. Sepsis. Very good. So most common cause of late death in a patient of burns beta is sepsis, definitely. Okay. And what is the most common organism to cause sepsis in a patient of burns? Previous year question. Most common organism to cause sepsis in a case of burns beta. Do tell me that. We know most common cause of late death is also sepsis, and most common cause of death in a patient of burns overall is also sepsis beta. Okay. Because the patient of burns becomes immunocompromised and there is loss of skin. The entry of organism is easier. Very good. The most common cause of sepsis in a patient of burns has to be Pseudomonas beta. Pseudomonas aeruginosa is the organism. Very good. That is important. Now answer this question beta. An elderly male has been rescued from a burning building. He was lying unconscious when spotted by the rescue team. His face is blistered and eyelids are swollen. Blood pressure is 114 by 76 millimeters of mercury. Heart rate is 90 beats per minute and respiratory rate is 30 breaths per minute. Next step in management should be. Next step in the management of this patient should be. Follow. A, B, C, D. What do you think? Very good. Why endotracheal intubation? Why we have to intubate the patient beta? What do you think? What is the reason? What are you suspecting in this patient? So we know a patient of burns which is there is also considered as a case of trauma, and any patient of trauma has to be managed according to the ATLS protocol, Advanced Trauma Life Support. And according to ATLS protocol, the first step is to save the life of a patient, that is basic resuscitation. And the sequence that is followed for basic resuscitation in a case of trauma is always A, B, C beta, airway, breathing and circulation. So utmost priority is given to the airway, followed by breathing, followed by circulation. Now important is beta, why airway management is required in this patient. First thing, you can see the BP and the heart rate of the patient seems to be stable. But the respiratory rate of the patient is 30 breaths per minute. Normally it is 12 to 20 breaths per minute beta. So here the patient is having tachypnea, that is a fast breathing. Fast breathing the patient generally has when he is not able to breathe properly for one reason. Second, they have said beta, face is blistered and eyelids are swollen. So as I told you, any burn in the face or neck region, you always have to suspect inhalational burns beta. Any burn in the face or the neck region, if they say beta, you have to suspect inhalational burns. So here we are suspecting that the patient might have had inhalational burn, and if inhalational burns are seen in a patient beta, Bailey and ATLS clearly say you have to go for an early elective or a prophylactic intubation. What do I mean by this? Even if the patient is not having a very severe respiratory distress, better go for a prophylactic or early intubation in the patient. Reason is, if there is inhalational burns, the edema of the airway will keep on increasing, and after a point of time, the swelling will be so much that you will not even be able to see the vocal cords. Therefore, the intubation becomes difficult. So, intubation as early as possible should be done in this patient beta. That has to be remembered. Clear? So that is important. Even oxygen by bag and mask would have been useful, but as it is a case of inhalational burns beta, only oxygen by bag and mask will not help because the edema will keep on increasing over here, and bag and mask ventilation is not going to help. Normal saline 1000 ml bolus, definitely we will give it beta 1 liter of normal saline, but that is done usually after airway or breathing management. Then we go for a circulation in the patient. Okay? So that is important. Now if they say beta, how to calculate the total body surface area of burns? We know the calculation of total body surface area of burns. How much body surface area has been burned is done most commonly by this rule beta, known as Wallace's rule of 9. Now according to the Wallace's rule of 9 beta, each and every body part is going to be 9% except, and this has been a repeated question of your exam. So please remember beta, each and every body part is 9% beta except the genitalia and perineum. So do remember, the genitalia and perineum will constitute only 1% of the total body surface area. Okay? So head and neck is 9%, chest or anterior thorax is 9%, अपर बैक और पोस्टीरियर थोरैक्स इज 9%, ठीक है. अब anterior abdomen is 9%, posterior abdomen और lower back is 9%. One upper limb is 9%, one lower limb is 18% beta. Now one lower limb when I say is 18%, anterior lower limb will be 9%, posterior lower limb will be 9%, and remaining 1% is the genitalia and perineum. Now even we have a modification for the Wallace's rule of 9 that we have discussed in class. But if they ask you which is the best rule to calculate the total body surface area in children, so for children we have a modification of Wallace's rule of 9, but that's not the best one. So the best rule for calculating the total body surface area of burns in children is the Lund and the Browder charts, beta. So these Lund and the Browder charts are the best formula, best rule to calculate the total body surface area of burns in children. Okay? What is the rule that is used for patchy burns? Anybody? What is the rule that is used for patchy burns? To calculate the total body surface area of burns in patchy burns, what is the rule used called as? Palm rule. Very good. In a case of patchy burns, beta, definitely the best rule which is there, it is the palm rule. One palm of the patient will be equal to a 1% of his total body surface area, beta. Equal to 1% of his total body surface area. No issues with this, anybody? That is important. Now, please remember, beta, if I talk about this next question out here. Here we have a 56-year-old male who is burned while sleeping, beta, in his home. His right upper and the lower extremity and the anterior aspect of the upper chest have extensive second degree burns. A second degree burn is characterized by which of the following? We know there are 4 degrees of burns, beta. First degree burn mein the patient is going to have pain, swelling, redness, all the signs of inflammation will be there in the patient, beta, and it is just a superficial burn involving the epidermis. Second degree burns are of two types, beta. Second degree superficial and second degree deep burns. Second degree superficial burns may definitely, till the time you can answer in the chat box, okay? Second degree superficial burns mein beta, again there will be signs of inflammation like pain, redness and swelling, beta. Even in second degree deep burns there is pain, redness and swelling, sometimes pallor can be there, okay? Now in second degree superficial burns there is damage to the epidermis and the partial dermis, and second degree deep burns mein there is damage to the epidermis and the complete dermis, beta. Third degree burns mein definitely here there is damage to the epidermis, dermis as well as the subcutaneous tissue. And as the nerves are definitely damaged, beta, the patient will have no pain. Yes, in third and fourth degree burns, as the nerves are damaged, the third and fourth degree burns are painless, beta. Or as the nerves are damaged, definitely the patient is not going to have any sensation, so there will be anesthetic burns. So first and second degree burns are painful, but third and fourth degree burns are painless, also called as anesthetic burns, beta. Yeah. And in third degree burn, there is a classical appearance also, beta, where there is a blackish leathery appearance of skin. That blackish leathery appearance of skin is known as an eschar, beta. So that eschar will be formed in a third degree burn as well. Okay? And we know that eschar acts like a compression band. It may be formed around the chest, beta, and it may cause compression of the chest, which will lead to hypoxia in the patient, or that may be formed around the limb of the patient, beta, which can cause compression of the nerves and the blood vessels, leading to compartment syndrome. The eschar may cause compression of the chest or compression of the limbs, beta. And what is the treatment of a eschar, anybody? What is the treatment of a eschar? We will take a blade and make multiple incisions over the eschar so that the pressure of the eschar is going to be released, beta, and the patient is either able to breathe or the compression on the limb is also released, beta. Very good. And that is called as escharotomy. So compartment syndrome may we do fasciotomy. Just like that, in cases of eschar, we have to do a escharotomy, beta. That has to be remembered. Shabash. So, and fourth degree burns mein there is damage to the epidermis, dermis, subcutaneous tissue, even the muscles, beta. Okay? So that has to be remembered. Now, here they have asked you which is the classical feature of second degree burn. Option A says eschar formation. I've told you that eschar, that blackish leathery appearance of skin, is formed in third degree burns, not second degree. Option B says pearly white appearance. Pearly white appearance which is there, but it is usually seen in third, fourth degree burns, definitely, because in first and second degree burns, redness is more characteristic. Okay? Third, next we have anesthetic lesions. Beta, anesthetic means no sensations, and no sensations will be seen when the nerves are damaged. We know nerves are damaged usually, or anesthetic burns are seen in third and fourth degree, beta, not second degree burn. So your answer has to be option D, bache, that is erythema and bullae formation. Erythema is nothing else but redness, and bulla is nothing else but blisters, beta, fluid filled regions. And we know bullae or blisters is a very characteristic feature of second degree burns, beta. If you have to choose one, that Blister formation or blistering is a classical feature of second degree superficial or second degree deep. What is your answer? Second degree में भी choose करना है. You have to choose one. So blisters is a characteristic feature of second degree superficial or second degree deep. What is your answer? बोलो. So then it is second degree superficial beta. Very good. So second degree superficial which is there, second degree superficial will have a more characteristic feature of blistering beta. So याद रखना, blistering will be a more characteristic feature of second degree superficial burns. That has to be remembered. ठीक है. Blisters are seen in both the second degree burns, but single best answer has to be second degree superficial if you have to choose one. Now if I talk about the definitive management of these burns degree wise beta, first degree burns made is very superficial burns beta. So in first degree burns nothing is required, only exposure is done. Yes, not even dressing. So first degree burns mein beta only exposure has to be done. Second degree burns may we go for dressing. And if I talk about dressing, which is the most common ointment used for dressing in burns beta, please tell me that. Dressing will be required for second, third, fourth degree. Second degree burns mein the definitive management is dressing. Please tell me which is the most common ointment used for dressing in a case of burns. It is 1% silver sulfadiazine beta. So 1% silver sulfadiazine is the most common ointment used for dressing in a case of burns beta. Very good. That has to be remembered. If they ask you which is the only ointment which can penetrate the eschar but has a risk of metabolic acidosis, which one is that? The only ointment which can penetrate a eschar but has a risk of metabolic acidosis and causes a lot of pain is which one beta? Not mupirocin. Mafenide acetate beta. The ointment which can penetrate a eschar, can cause metabolic acidosis and can lead to a lot of pain is mafenide acetate bache. Yes, that has to be remembered. Now in third and fourth degree burns beta, the definitive management is whatever is the dead necrotic tissue, you have to remove it. That is debridement. We have to keep on doing regular dressing, and when a healthy granulation tissue appears, then we have to go for skin grafting. So debridement and skin grafting is the definitive management for third and fourth degree burn beta. Okay? That is important. Now here they ask you, beta, child weighs 20 kgs who was brought to you with burns and fluid resuscitation, okay, was to be started. Total body surface area involved in this child is around 30%. Calculate the fluid requirement according to the Parkland's formula. Please tell me what is the Parkland's formula beta. The modified Brooks version of Parkland's, we know it is 2 into body weight into total body surface area of burns. What is the conventional Parkland's formula beta? Here they have just mentioned Parkland's. We know ATLS also has a formula for calculating the amount of fluid to be given in a case of burns. For ATLS beta, the formula for an adult is 2 into body weight into total body surface area of burns. For a child less than equal to 14 years of age, it is 3 into body weight into total body surface area of burns. And in case of electrical burns, more fluid has to be given. Therefore, according to ATLS, in electrical burns, it is 4 into body weight into total body surface area of burns beta. But according to Parkland's formula, it is 4 into body weight into total body surface area of burns. The conventional Parkland's formula is 4 into body weight in kilograms into total body surface area of burns. So please tell me how much amount of fluid should be given to this child in the first 24 hours. How much amount of fluid to be given to this child in the first 24 hours? So you will calculate it as 4 into body weight, that is 20 kg, into total body surface area involved is 30%. So 4 into 20 into 30, how much it would be? $2,400 ml. Very good. So 2400 ml amount of fluid should be given to this child beta in the first 24 hours of burns. Now out of this 2400 ml beta, we know in the first 8 hours how much should be given. Out of this 2400 ml which has to be given in the first 24 hours, okay, how much should be given in the first 8 hours? How much should be given in the first 8 hours? Very good. 1200 ml, that is half amount of fluid, should be given rapidly beta in the first 8 hours, and the remaining half should be given over the next 16 hours. Okay, so 0 to 8 hours half amount of fluid, and 8 to 24 hours the remaining half fluid. Okay, so that has to be remembered. Shabash. No issues with this, anybody? Next important, this one beta. What is this? Here you are able to see, due to freezing temperature beta, like -40, -50 degrees Celsius, there was freezing of tissues, there was coagulation of blood, and there was decreased blood supply, causing ischemic necrosis in the tip of the fingers or in the tip of the toes beta. This condition is what is a case of a frostbite beta. This is a classical case of a frostbite. Whereas second one, this was due to a sub-freezing temperature beta, sub-freezing like 0, 1 degree, 2 degrees Celsius temperature. And this is a classical case of a trench foot beta. We know that frostbite, the first picture which is there, it is due to dry cold beta. Whereas the trench foot, the second picture, is due to moist cold, like the patient was standing in water for a very long duration of time, right? That is important beta. So dry cold, frostbite, moist cold, trench foot beta. Okay? If they ask you in both these conditions, please tell me what is the treatment of choice beta. What has to be done? Rapid rewarming or a gradual rewarming? What should be done? Rapid rewarming or a gradual rewarming? What should be done beta in the management? Rapid beta. Do you remember the recent update of Bailey? I've told you the recent update of Bailey. I've told you that it is rapid rewarming which is done beta. Do remember that recent update of Bailey says, okay, the chance of reperfusion injury is lesser. That's the reason definitely you can go for rapid rewarming. So according to the recent one, do remember that rapid rewarming has to be done beta at how much degree temperature? Maximum 42 degrees beta. So 40 to 42 degrees Celsius is the temperature range in which you should go for a rapid rewarming beta. It can be less than 42, but don't go beyond 42 beta. Okay? So it is usually around 40 to 42 degrees Celsius in which rapid rewarming has to be done. First thing. Second important beta, we have to give a lot of analgesics or painkillers, because during rewarming the patient will experience a lot of pain. And third, the patient has to go for a surgery. Whatever part has undergone gangrene or necrosis, we have to cut that beta. So delayed amputation or early amputation has to be done. Please tell me. Delayed or early amputation, what has to be done? Follow. Delayed surgery. Reason is we will let that line of demarcation appear properly beta, and once that line of demarcation has appeared clearly, then we will go for amputation. Okay, so that is a delayed surgery or a delayed amputation to be done. Shabash. Now important is beta, if I talk about breast cancer, we know breast cancer is a hormone dependent cancer bache. So it is mainly dependent on estrogen. Yes, even progesterone may increase the risk, but mainly it is estrogen. So the most important risk factor for breast cancer is a hyperestrogenemia beta, more estrogen level in the blood. Now hyperestrogenemia will be due to increase in the number of menstrual cycles. If a female had more number of menstrual cycles in her life, she had more exposure to estrogen and higher risk of breast cancer. That is early menarche and late menopause. Because if she had an early menarche and a late menopause beta, her reproductive lifespan was more, number of menstrual cycles were more, therefore exposure to estrogen was more. Okay? So be careful when you mark it. It is early menarche and late menopause, not vice versa. Next is obesity. Reason is beta, if patient is obese, more amount of adipose tissue, more amount of aromatase enzyme, more convergence of androgen into estrogen, and therefore higher risk of breast cancer. Okay? Next, nulliparity beta. If a female is nulliparous or nulligravida, the female has never conceived, she was never pregnant, she was never lactating. Normally when the patient is pregnant, whenever she lactates beta, she has amenorrhea, she has no menstrual cycles, and therefore she is protected from estrogen. But if the female was never pregnant, never lactating beta, in that condition she will have a more exposure to estrogen and therefore higher risk of breast cancer. So nulligravida, nulliparity are risk factors beta, whereas multigravida and multiparity are protective factors. Pregnancy and lactation are protective factors. Okay? HRT, hormone replacement therapy beta, because we give high doses of estrogen and progesterone to the patient, therefore HRT is a risk factor. But on the other hand, OCPs beta, OCPs, oral contraceptive pills, they do not increase the risk of breast cancer, do remember. Neither they are protective nor they are risk factors beta. Okay? OCPs have no relation with breast cancer because very low doses of estrogen and progesterone are given in OCPs beta. Okay? Next important, if I talk about which is the most common gene mutation in breast cancer. So do remember 90% of the breast cancer beta are sporadic in nature. only 10% breast cancers are familial in nature. And we know the most common gene mutation in breast cancer or most common gene mutation in sporadic breast cancer is P53 beta. It has to be P53. It is rather the most common gene in most of the cancers of your body. Yes, if they say that which is the most common gene mutation in familial breast cancer, which runs in the families, which is hereditary in nature. The most common gene mutation in familial or hereditary breast cancer is BRCA1 followed by BRCA2 gene mutation. We know BRCA1 on chromosome number 17, BRCA2 on chromosome number 13. Now, BRCA1 and BRCA2 gene mutation beta, they definitely increase the risk of breast cancer. But apart from that, they also increase the risk of OCP cancer. OCP is the mnemonic that I told you beta to remember. Out of this beta, do remember that BRCA1 is more commonly associated with breast cancer. Second most commonly it is associated with ovarian cancer. So O stands for ovarian cancer beta. Okay? O for ovarian cancer, C for colorectal cancer, P for pancreatic and prostate cancer beta. Again I am repeating, O for ovarian cancer, C for colorectal cancer, P for pancreatic and prostate cancer. We know O and C, that is ovarian and colorectal cancer, are more common with BRCA1 gene mutation, but the P cancers, that is pancreatic and prostate cancer, are more common with BRCA. We know that if they ask you what is the most common site of breast cancer, Sarkari question beta. So most common site of breast cancer is the upper outer quadrant of the breast beta, towards the axilla. So upper outer quadrant of the breast is the most common site of breast cancer. Can anybody type in the chat box which is the least common site of breast cancer? Sabse kam, least common site of breast cancer. We know that if they ask you which is the most common type of breast cancer, so the most common type of breast cancer is IDC beta. What is IDC? Invasive ductal carcinoma. So invasive ductal carcinoma is the most common type of breast cancer beta. Do remember that. Okay? And if I talk about one more cancer, that is ILC, that is invasive lobular carcinoma. In invasive lobular carcinoma beta, the malignant cells are arranged one behind the another, giving a very classical appearance known as the single file pattern or the Indian file pattern beta. So single file pattern or Indian file pattern is a feature of invasive lobular carcinoma beta. Okay, so that is important. Very good. Please remember, most common site is upper outer quadrant. Completely opposite to this is the least common site beta, that is lower inner quadrant. Okay, most common upper outer, least common lower inner quadrant beta is the least common site. Do remember that. Okay. If they say, if a patient of breast cancer comes to you, we know the most common symptom or complaint in a case of breast cancer is going to be a breast lump or a breast mass. Whenever a female comes to you with a breast lump or a breast mass beta, the best method for diagnosis or the best method for examination is known as triple assessment. Any patient coming to you with a breast lump, the best method is triple assessment. If I talk about triple assessment, bache, so do remember, first step is history taking and clinical examination. So you have to do a proper history taking and clinical examination. Can anybody let me know in the chat box which is the best method for palpation or for clinical examination of a breast lump? The best method for palpation or clinical examination of breast lump. Now, once you do a clinical examination, then you will send your patient to a radiologist for a radiological investigation. We know radiological investigation for a breast lump. If the patient is less than 40 years of age, then radiological investigation of choice is an ultrasound breast. But if the female is more than 40 years of age, then the radiological investigation of choice is a mammography. So less than 40 ultrasound, more than 40 mammography beta. Yeah. And after that, definitely, once the radiologist has given you the report, there will be score beta which will be given to you. And that scoring system is known as BIRADS. So breast imaging reporting and data system. Okay, breast imaging reporting and data system. Depending on that BIRADS score, you will decide the next step beta. If he says it is BIRADS 2, that means he says it is 100% benign beta. And when he says BIRADS 2 or 100% benign, you do not go for anything else. You just continue routine screening. Annually, you will call the patient for screening beta. Okay. But when he says BIRADS 3 means he says probably benign. He is 98% sure beta it is benign, but still there is a 2% risk. So BIRADS 3, when he says probably benign, you will not call the patient after 1 year, but rather you will call the patient after 6 months beta. That is called as a short interval follow-up. When they say it is BIRADS 4 or BIRADS 5 beta, then it is suspicious of a malignancy or suspicious of a cancer. So BIRADS 4 and BIRADS 5 mein, then we will go for the third step of triple assessment. And the third step of triple assessment is a histopathological examination. That histopathological examination, either I can go for a FNSE, fine needle aspiration cytology, or a true cut biopsy beta. Obviously, if they ask you which one is better, we know it is true cut biopsy. Rather, the investigation of choice for a breast lump or a breast cancer has to be a true cut biopsy. And the size of needle that we commonly use nowadays is 14 gauge. 14 gauge needle is used for true cut biopsy. Not an option, go for 16 gauge. But 14 gauge will be the best answer. Very good. It is the dial clock method, beta, when we start from the center and then go towards the periphery. So dial clock method is the best method of palpation or clinical examination for a breast lump. Okay. Now, next important beta, if they ask you about the staging of breast cancer, we know the TNM staging of breast cancer. This is what you have to remember. T1 means the cancer is less than equal to 2 centimeters in size. T2 means it is more than 2 centimeter but less than equal to 5 centimeter. T3 means more than 5 centimeters in size. T4A, involvement of chest wall. T4B, involvement of skin. T4C, involvement of both, that is T4A plus T4B, that is chest wall plus skin. T4D, inflammatory breast cancer beta. Okay. Now important is easy to remember. T1 less than 2, T2 2 to 5, T3 more than 5. T4A chest wall, T4B skin, T4C both, and T4D inflammatory. Worst prognosis is associated with T4D, that is inflammatory breast cancer beta. Now important is we know that chest wall involvement means involvement of the ribs, intercostal muscle or the serratus anterior muscle, but pectoralis muscle involvement is not considered as a separate staging beta. Yes, pectoralis muscle involvement is not considered as chest wall involvement. याद रखना है. Second important, skin involvement means ulceration of the skin, satellite nodules, ठीक है, or pudgy orange. So ulcerative lesions, satellite nodules or pudgy orange. But if they say when pudgy orange is less than 1/3 surface area without any sign of inflammation, okay, pudgy orange is involving less than 1/3 of the surface area without any sign of inflammation, then it is T4B, that is skin involvement. But when they say pudgy orange is involving more than 1/3 surface area of skin, when it is involving more than 1/3 surface area of skin with signs of inflammation like redness, swelling, all of that, then it is T4D, that is inflammatory breast cancer. Okay, so pudgy orange more than 1/3 surface area with signs of inflammation, it has to be T4D, inflammatory breast cancer, PYQ of FMG exam. Okay? If they say beta N1, so N1 means involvement of the axillary lymph nodes, and these axillary lymph nodes are mobile beta. N2A means involvement of the axillary lymph nodes, but these axillary lymph nodes are fixed or they are matted, attached to each other. N2B, involvement of only internal mammary lymph nodes without involvement of any axillary group of lymph node beta. N3B is involvement of both, that is internal mammary as well as axillary group of lymph nodes. These are the most important stages to be remembered beta. So N1, mobile axillary lymph node. N2A, fixed or matted axillary lymph node. N2B, only internal mammary lymph node. N3B, both. Okay. Now important is beta, please remember, depending on the TNM staging, we can further classify this breast cancer into various types, bache, like early invasive breast cancer, that is stage 1 and stage 2 together will be called as a early invasive breast cancer. Next, stage 3 ABC. Stage 3 ABC will be called as locally advanced breast cancer, and stage 4 will be called as advanced breast cancer. And we know stage 4 or advanced breast cancer means what? T stage does not matter, N stage does not matter, M1, matlab any T, any N, but M1 beta, distant metastasis is present. If distant metastasis is present, then directly the stage becomes stage 4 or advanced breast cancer. And we know in stage 4 or advanced breast cancer, patient kiske bharose? Upar wale ke. That is, palliative care has to be given only in advanced or stage 4 breast cancer. Clear? Now if I talk about stage 1 and stage 2, that is early invasive breast cancer beta, here we will try to only remove the lump, that is lumpectomy or a quadrantectomy. That means we are trying to conserve or we are trying to save the breast beta. So in early invasive breast cancer, we can go for a breast conservation surgery beta, BCS. And in breast conservation surgery, the margin that we take is usually around 1 centimeter. As the margin we take is only 1 centimeter beta, that is the reason there is a very high chance of recurrence after a breast conservation surgery. So BCS should always and always be followed by radiotherapy. So whenever breast conservation surgery is done, it should always be followed by radiotherapy, that is mandatory beta. But in case if we are not able to give radiotherapy or if you are not able to perform BCS, then what is another option for early invasive breast cancer? Another option for early invasive breast cancer is simple mastectomy. Simple mastectomy is removal of the breast, pectoral fascia and the nipple areola complex. Yeah. Next is locally advanced breast cancer, LABC, that is stage 3 beta. In stage 3 or locally advanced breast cancer, the size of the tumor is large. The first thing to do is to decrease the size of tumor beta by giving a neoadjuvant chemotherapy. So what is the purpose of neoadjuvant chemotherapy prior to surgery? The thing is to decrease the size of tumor, also called as downstaging the tumor beta. Stage kam ho jayegi na. Please remember, neoadjuvant chemotherapy in LABC or stage 3 is given to downstage the tumor to decrease the size of the tumor. After the size of the tumor has been decreased, then after neoadjuvant chemotherapy, we have to go for MRM. What is MRM? Modified radical mastectomy, beta. Modified radical mastectomy means removal of the breast, pectoral fascia, nipple areola complex. Along with that, we have to remove level 1, level 2 and level 3 axillary lymph node, and we can also remove the pectoralis minor muscle plus minus pectoralis minor, because in some types of MRM we remove pectoralis minor, in some type we do not remove pectoralis minor. Matlab, if I remove the pectoralis minor, it is called as a Patey's MRM. If I do not remove the pectoralis minor, it is either a Auchincloss MRM or a Stepey's MRM beta. Okay? Sorry, Scanlon's MRM beta. Okay? Auchincloss or a Scanlon's MRM. No issues with this, anybody? That is important. After modified radical mastectomy beta, we have to give radiotherapy to prevent any recurrence in the patient. Okay? So neoadjuvant chemotherapy followed by MRM followed by radiotherapy is done in stage 3 or a locally advanced breast cancer. Next is, if it is a hormonal breast cancer beta, that is ER/PR positive breast cancer, when estrogen and progesterone receptors are present on surface of the breast cancer, then the treatment is hormonal therapy. Now, hormonal therapy in a premenopausal female beta is nothing else but SERMs beta. What are SERMs? Selective estrogen receptor modulator. And these selective estrogen receptor modulators are drugs like tamoxifen. So when the female is in the reproductive age group or in the premenopausal age group, give SERMs like tamoxifen. The most common side effect of tamoxifen or other SERMs is hot flushes beta. Yes, redness and sweating. That is called as hot flushes. Yes, an important side effect of tamoxifen can be endometrial hyperplasia or endometrial cancer, but it is not the most common. Okay? If they ask you post-menopausal female, that means after menopause beta, then the hormonal therapy of choice in the female has to be aromatase inhibitors. Aromatase inhibitors matlab drugs like letrozole, anastrozole or exmustine beta. Letrozole is commonly used. Side effect of these aromatase inhibitors is osteoporosis, because after menopause, already the level of estrogen is low. We are further decreasing the level of estrogen by giving aromatase inhibitors. Therefore, the major side effect is osteoporosis. Therefore, you should start calcium, vitamin D or bisphosphonates beta along with aromatase inhibitors. HER2 new positive breast cancer. Previous year question. HER2 new positive breast cancer beta, the drug of choice is a monoclonal antibody known as trastuzumab. This trastuzumab is also known as Herceptin beta. Along with this, we give chemotherapy, but yes, the best answer has to be trastuzumab or Herceptin. Now, if I talk about distant metastasis beta, distant metastasis in breast cancer is usually seen to the bones. Which bones? Mainly the spine or the vertebral column. Which vertebra? The lumbar vertebrae. The most common site of distant metastasis in breast cancer is the lumbar vertebrae, and we know it can cause both types of metastasis: bone breaking, that is osteolytic, as well as bone forming, that is osteoblastic beta. But we know that breast cancer, just like any other cancer, causes osteolytic metastasis more commonly, less commonly osteoblastic beta. Okay? And it is usually seen via the Battison's plexus of veins beta. Okay, it is usually seen via the Battison's plexus of veins, which are valveless veins. Next is a picture where the nipple has been pulled inside. When the nipple is pulled inside beta, that is called as nipple retraction. And we know nipple retraction is not due to involvement of skin. It is due to involvement of the lactiferous ducts. When the cancer involves the lactiferous ducts, the nipple is pulled inside beta. Next, here you can see the skin has been pulled inside. When the skin is pulled inside, that is called as dimpling or puckering. We know that dimpling or puckering is again not due to skin involvement. It is due to involvement of the suspensory ligaments of Cooper. When the suspensory ligaments of Cooper are going to be involved beta, the skin will be pulled inside, leading to dimpling or puckering. So neither nipple retraction nor dimpling or puckering are skin involvement beta. Now once you have removed the breast beta, you can go for a breast reconstruction surgery. Either for breast reconstruction surgery, you can use implants beta. Those are made up of silicone gel. We can use the silicone gel implants in the patient, or we can use some autologous grafts or flaps that is taken from your own body. Now these flaps that are taken beta, the best flap is DIEP flap. DIEP, that is deep inferior epigastric artery perforator flap. Okay, the best flap for breast reconstruction is the DIEP, deep inferior epigastric artery perforator flap. But the most commonly used flap is a tram flap beta. Tram flap, that is transverse rectus abdominis myocutaneous flap. Transverse rectus abdominis myocutaneous tram flap is the most common one. Can anybody tell me why DIP flap is better than tram flap? Why DIP flap is better than a tram flap? बोलो. Why DIP flap is best flap? Why it is better than a tram flap? Q. What is the reason? In DIP flap beta, both are taken from abdomen itself. Now, the difference is in DIP flap beta, we only take the skin and the subcutaneous tissue. Yes, in a DIEP flap, we only take skin and the subcutaneous tissue. But in a tram flap, we take skin, subcutaneous tissue as well as muscles beta, myocutaneous na. So in tram flap, we take skin, subcutaneous tissue and muscles. As we also take muscles beta, the abdominal wall becomes weaker and there will be a more chance of abdominal wall hernia. So please remember bache, that as there is a more risk of abdominal wall hernia or a ventral hernia after a tram flap, that's the reason definitely beta. Okay, that's the reason definitely. Okay, you remember that it is not considered as the best flap. Okay, as there is more chance of hernia, abdominal wall hernia after tram flap, it is not the best one. DIP is better because there is less chance of hernia or almost no chance of hernia. Okay, now please tell me this question over here. Answer this question. 55-year-old woman presents with a large 5 centimeter mass in her right breast. On physical examination, there is overlying ulceration of the skin and concern for fixation to the underlying pectoralis muscle. She is noted to have several enlarged matted axillary lymph nodes on examination. Core biopsy reveals ER negative, PR negative, HER2 negative invasive ductal carcinoma of the breast. After staging, scans demonstrate no evidence of any distant metastatic disease. A management should begin with. Now, first of all, please tell me what is the stage of this breast cancer. मुझे stage बताओगे तुम chat box में. What is the stage of the breast cancer? What is the stage of breast cancer? पूरा. TNM. बोलो. It's T4B. Very good. Why T4B? Though they say 5 centimeter mass beta, but further they have said there is ulceration of skin. And as soon as we know they say ulceration of skin, that means there is skin involvement. As there is skin involvement, it becomes T4B. Okay. So T to ho gaya, T4B it is. Next, N. They have said there is involvement of axillary lymph nodes and they are matted. When axillary lymph nodes are involved and they are matted, they are attached to each other. That is N2A beta. So it is T4B, N2A. Okay, and what is M? M0. Because they have said there is no evidence of distant metastasis, so it is M0 beta. Okay, so T4B, N2A, M0. We know this means if it is T3 or T4 beta, usually it comes. Okay, if it is T4 or T3 or T4, or it is N2 and above, it comes in locally advanced breast cancer beta, and locally advanced breast cancer it is stage 3. Okay, what is the management? What is your answer? A B C D bolo. Stage 3, that is locally advanced breast cancer. Very good. Here please remember beta, here they have asked the management should begin with. We know locally advanced breast cancer or stage 3 mein. Bolo to say something other. Yes, the management should begin with neoadjuvant chemotherapy beta, because we have to decrease the size of the cancer. Downstaging of the tumor should be done. And then we go for a MRM, that is modified radical mastectomy, and then we go for a radiotherapy beta. They have just asked should begin with. So answer has to be option B beta, neoadjuvant chemotherapy we will start with, followed by MRM, followed by radiotherapy. Clear? So answer should be option B. We know that aromatase inhibitors are hormonal therapy beta, and we cannot use hormonal therapy in this patient. Why? ER negative, PR negative, HER2 negative. If obviously hormonal receptors are absent beta, we cannot use hormonal therapy for the management. Na? That is important. We know ER negative, PR negative, HER2 negative is a basal type of breast cancer which has the worst prognosis beta, right? That has to be remembered. No issues with this, anybody? Now, what is this tumor out here, beta? What is this tumor called as? What is this tumor known as? Very good. This is a massive breast tumor, beta, and due to that, there is compression of the blood vessels supplying the skin, due to which we are able to see color changes on the skin, beta, due to pressure necrosis. This is a classical case of a phylloids tumor, beta. Phylloids tumor is also known as cystosarcoma phylloids, and this phylloids tumor or cystosarcoma phylloids is also known as Brody's disease, beta. याद रखना, BRODIE is also known as Brody's disease as well. It's one and the same thing. Now, though it is a very massive or a huge breast tumor, beta, we know it is always superficial. Yes, though it is massive, okay, it will always remain above the pectoral fascia, beta. It will never invade the pectoral fascia. Therefore, it will always remain superficial and it may be mobile. Yes, though it is very massive, it is somewhat mobile, beta, that we know. So, phylloid tumor is more commonly seen in third or fourth decade of life. It is common. It is more commonly benign, beta. 90% cases of phylloid tumor are benign. Only the 10% cases of phylloids are malignant in nature, beta. It is a massive breast tumor, rapidly growing in size, somewhat mobile. Skin color changes are seen. Investigation of choice is a true cut biopsy. When I do a true cut biopsy, we are able to see a leaf-like structure on the histopath, beta. Okay. Now, please tell me what is the treatment in a case of phylloid tumor. Please tell me what is the treatment in a case of phylloid tumor, beta. What should be the management? What should be the management in case of phylloid tumor? So, very good. The management in a case of phylloid tumor has to be a wide local excision. Beta, wide local excision ka matlab, we have to remove the tumor along with 1 to 2 centimeter normal margins. That's it. So the management in cases of phylloid tumor is a wide local excision, except in certain cases where we go for a simple mastectomy, beta. And what are the cases of phylloid tumor when we have to go for a simple mastectomy? First condition, if it is a malignant phylloids, beta. Second, if it is a massive phylloid tumor, like usually in this case. Or third condition, when it is a recurrent phylloids. Again, it has appeared. So malignant phylloids, recurrent phylloids, or in a malignant phylloids, recurrent phylloids, or in a case of massive phylloids, beta, we go for simple mastectomy. Yes, that too not a MRM. MRM is never required in a case of phylloid tumor because it does not involve any lymph nodes, and second, it does not invade the pectoral fascia. Okay, so even in malignancy, a massive tumor, or in recurrence, we only go for a simple mastectomy. Otherwise, it is only wide local excision which is done. Now, what is this? This is a mammography, beta, which shows you a macro calcification. And this macro calcification is known as a popcorn calcification. What is that breast tumor where you are able to see a popcorn calcification on mammography? You know, popcorn calcification on a chest x-ray is a feature of lung hematoma or a pulmonary hematoma. And popcorn cells on biopsy is a feature of non-classical Hodgkin's lymphoma. Okay? But a popcorn calcification on a mammography, very good. It's a classical case of fibroadenoma. And we know, beta, fibroadenoma is a benign breast tumor. Rather, it is the most common benign breast tumor, beta. It is also the most common cause of breast lump. That means any female who comes to you with breast lump, the first thing that should strike your mind is a fibroadenoma. We know that fibroadenoma is going to involve more commonly younger females, beta, 15 to 25 years of age, 15 se 25. Most commonly fibroadenoma involves younger females between 15 to 25 years of age. That has to be remembered. Second thing to be remembered, beta, it is a painless firm lump, but firm lump. Yes, it will be painless. It will be firm. Firm, why? Because a lot of fibrous tissue is there, so it will feel somewhat hard. So it is painless, firm breast lump, beta. And please tell me, it will be very, very freely mobile. Yes, as it is freely mobile, beta, it is also known as a breast mouse. It is painless, firm, freely mobile breast lump, beta, which is a complaint of fibroadenoma patient. Now in fibroadenoma, what is the investigation of choice, beta? What is the investigation of choice in a patient of fibroadenoma breast? Hello? Do remember, investigation of choice is a ultrasound, beta, with or without FNSC or a biopsy. Yes. Investigation of choice. Single best answer is ultrasound with or without FNC or biopsy. Reason is, if you do an ultrasound and the radiologist says it is BIRATS 2 beta, then you don't even have to go for the third step. But yes, if the radiologist says it is 4 or 5, then you may go for a FNC or a biopsy beta. Okay, so ultrasound with or without biopsy. If single best answer has to be ultrasound with or without biopsy, agar if you have to choose individually, then ultrasound can be the answer. Okay? Now, if they ask you treatment beta, we know fibroadenoma is a benign breast tumor. Treatment is just observation and follow-up. The treatment of fibroadenoma breast is just observation and follow-up beta. But there are certain conditions where we may need a surgical excision. Surgical excision or surgical removal of the fibroadenoma is done in various conditions. But the most common indication is Doctor Saab acha nahi lag raha. It doesn't feel good. That is cosmetic beta. The most common indication of removal of fibroadenoma is cosmetic indication. Other indications can be if it is a giant fibroadenoma more than 5 centimeters in size beta, giant fibroadenoma more than 5 centimeter, or it is rapidly growing, or it is becoming painful, or the patient is having family history of breast cancer. In any of these conditions, it's better to get it removed. Now, when you remove the fibroadenoma beta and when you send it for a histopathological examination, on histopath you are able to see a classical appearance where there is excess amount of fibrous tissue or fibrous trauma and it compresses the granular tissue beta, leading to a classical sign known as antler sign beta. So classical antler sign is seen on the histopath of fibroadenoma breast. Recent image based question of your exam, to remember that. Next, here you can see beta, there is complete dryness, cracking and destruction of the nipple areola complex. This dry, cracked and destroyed nipple areola complex is known as Paget's disease of nipple beta. We know Paget's disease of nipple is a marker of malignancy. That means if a patient was having a cancer or malignancy in the breast beta, definitely will be able to see this kind of a feature in the nipple. Investigation of choice is a punch biopsy. And when we do a punch biopsy beta of the skin, in the epidermis, you are able to see specialized cells. And those specialized cells are known as Paget cells beta. So in the punch biopsy of Paget's disease of nipple, you are able to classically see the Paget cells beta. Treatment, we know, depending on the staging of the cancer, underlying cancer, you have to treat the patient. So treatment is according to the underlying malignancy beta. Next, this condition where you are able to see the patient has a lot of pain in the breast beta, that is called as mastalgia, and the patient will have a constant breast pain, that means irrespective of menses. Therefore, it is a non-cyclical mastalgia beta. The patient comes to your OPD with a non-cyclical mastalgia or breast pain. Along with that, when you palpate the chest or the breast of the patient, you are able to feel a string-like structure or a cord-like structure. This string-like or a cord-like structure is nothing else but inflamed veins beta. Yes. So it is due to inflammation or thrombophlebitis of the veins beta. And this condition is known as Maunders disease, also known as string disease beta. Maunders disease, it is a self-limiting condition. Therefore, the treatment is only analgesics or painkillers. Next is the condition bluish reddish nodules on the breast of the patient. It is due to loco-regional recurrence beta. If there is a loco-regional recurrence of breast cancer, this kind of a picture is seen and that's called as cancer and cuirass. Then Sarkari picture. Here you are able to see beta edema of the skin over the breast, and this edema of the skin over breast is known as pudy orange. We know pudy orange is due to blockage of subdermal lymphatics beta. So due to blockage of subdermal lymphatics, there is pudy orange which develops in the patient and it is stage T4B bache. Reason, here they have not mentioned anything about the involvement of skin if it is less than 1/3 or more than 1/3. Second, here I am not able to see any sign of inflammation like redness or any swelling or anything. So definitely it will be T4B. Okay? If signs of inflammation were seen, I would have said T4D then. Okay? Now here there's a question beta. Answer this question over here. A postpartum female presented to the OPD with pain, fullness and fluctuant swelling in the breast. She gives history that the child refuses the feed but does not give any history of fever. What is the first line treatment option in this patient? First, tell me what is the provisional diagnosis beta. The image also has been given besides. Image has been given besides. Yes. So do remember beta, this is a classical diagnosis of breast abscess. Now why do I call it as a breast abscess? Two reasons for it. First, apart from pain and fullness in the breast beta, they have also mentioned about fluctuant swelling. We know that fluctuant swelling is a late sign which appears in a patient of breast abscess. Alongside, they have also given a picture beta which is showing me signs of inflammation like redness, swelling. There can be warmth also. A fluctuant swelling which is seen which may contain pus inside it. So it has to be a case of a breast abscess itself. Okay? You will be like, sir, they have not given any history of fever. But sometimes it happens as if breast abscess, I know fever is a very important feature, but still sometimes it happens that the patient misses out on the fever. The patient may not have a high grade fever because she was immunocompetent beta. Okay, so that is the reason, or the patient may have taken immediately paracetamol, so something like that. That's the reason beta. Like at times it may happen that the patient may not give you a history of fever, but other signs were there. Na, I've told you engorgement kab bolna hai. Yes, engorgement is more common, I know that, but we say engorgement more commonly beta when they say the baby is refusing the feed and there is pain and fullness in the breast. Only this. Refusal of feed, pain and fullness. Only these three things. Then I will call it as a breast engorgement when there is excess collection of milk in the breast and we have to express out the milk with warm moist compresses. Okay? Then if there is cracking of nipple and from the baby's mouth beta, if the staph aureus enters inside the breast and that causes infection of the breast, that is mastitis. The most common cause of mastitis is staph aureus. Here the patient may have signs of inflammation like pain, redness, warmth, and the patient may have fever. Treatment is only antibiotics and breast support. Antibiotics के लिए we give commonly amoxiclav, amoxicillin plus clavulanic acid. Not in option, go for cloxacillin or dicloxacillin. Okay, and third condition, when there is pus collection inside the breast leading to a breast abscess. Here, I told you beta, when there is breast abscess in the patient, they will give you certain hints. What are the certain hints? Understand. First, they may mention the patient is having high grade fever along with chills, along with signs of inflammation like pain, redness, swelling. Second, they may give you a late sign of breast abscess called as fluctuant swelling because there is pus collection inside, so fluctuant swelling. Third, they may give you ultrasound shows fluid collection beta. Third, they may give you ultrasound is showing fluid collection. And fourth, they may give you a picture like this. So if these four things are present, high grade fever, fluctuant swelling, ultrasound showing fluid collection, or this picture, it has to be a case of breast abscess. So here definitely two things were present, fluctuant swelling and picture. So therefore it has to be a case of a breast abscess beta. Common cause for breast abscess is also staph aureus, and the source for the staph aureus is the baby's mouth. Now here we know that the best management or the most appropriate management for breast abscess is incision and drainage along with antibiotics. But have they asked us about the best management or the most appropriate management? No. In your examination, they commonly ask you about the best one. So then it would have been incision and drainage along with antibiotics. But here in the question, I've asked you about the first line management beta. And we have discussed in cases of breast abscess, the first line management is nothing else but an ultrasound guided aspiration beta. So ultrasound guided aspiration has to be done along with antibiotics is the first line management. We know we can do a ultrasound guided aspiration twice beta. Okay, one time we will do it. If it fails, we will do it the second time also. Okay, and after two times beta, then we may go for definitely a incision and drainage. Okay, so first line पूछे तो ultrasound guided aspiration with antibiotics. Best या most appropriate पूछे तो incision and drainage with antibiotics. Please tell me which is the number of blade that is used for incision and drainage for abscesses beta. Which is the number of blade used for incision and drainage for abscesses. We know here the patient is having multiple nipples beta, so this condition is known as polythelia. In second picture, the patient is having breast tissue but no nipples. If there is absence of nipples, that is called as athelia. Next, in the third picture, the patient is neither having breast nor nipples beta. If the patient is not having any breast tissue, then that is what is called as amastia or amasia beta. No breast tissue, that is amastia or amasia. Okay, and multiple breast tissues, polymastia or polymasia. Now here you are able to see one part of the chest is gone inside beta. Depression is seen on one part of the chest. Why? Because not only the breast tissue, even the pectoralis major muscle is absent. As breast tissue and pectoralis major muscle is also absent beta, this condition is known as Poland syndrome. If depression is seen, then it is Poland syndrome. If flat chest is seen, that is only amastia. Yeah, very good. It is number 11, blade used for IND, incision and drainage. We know if they ask you beta, which is the most common type of discharge from the nipple. The most common type of discharge from the nipple is the milk beta. But if they ask you if there is blood stained nipple discharge, what is the most common cause? We know that most common cause of a blood stained nipple discharge from a single duct is the duct papilloma. Most common cause for a blood stained nipple discharge from a single duct is a duct papilloma, and most common cause for blood stained nipple discharge from multiple ducts beta. Most common cause for a blood stained nipple discharge from multiple ducts is a breast cancer. If they ask you What is the most common cause of a serous or a pale yellow nipple discharge? Most common cause of a serous or a pale yellow nipple discharge beta is fibrocystic disease. We know fibrocystic disease is also known as fibroadenosis beta, which is going to cause cyclical mastalgia. Next, if they ask you most common cause of greenish, blackish or a bluish nipple discharge. Greenish, blackish, bluish nipple discharge, very characteristic of duct ectasia. What is duct ectasia? When the lactiferous ducts are going to dilate, the milk stays inside the breast for a longer duration of time. And as the milk stays over there for a longer duration of time, it may get infected, leading to a blackish, bluish or a greenish nipple discharge. If they ask you for duct ectasia, for fibrocystic disease, investigation of choice is a ultrasound breast beta. But for duct papilloma, we will not be able to pick up a duct papilloma on ultrasound beta because it is very small. For that, we have to, or we may have to go for investigations like a ductoscopy or a ductography beta. And after you confirm the diagnosis of duct papilloma or a ectasia or a fibrocystic disease, then the treatment. If single duct is involved beta, microdocectomy is done. What is microdocectomy? Removal of that single duct beta. But if multiple ducts are involved, we have to do a conical excision of the ducts. And that conical excision of ducts is known as Hadfield's operation. Yaad rakhna, in duct ectasia, more commonly we have multiple duct involvement. Therefore, it is Hadfield's operation, which is commonly done. But in duct papilloma, there is single duct involvement. So microdocectomy is commonly done. Cancer will always be treated according to the staging beta, not according to this. Clear to all of you now? That has to be remembered. Okay. Let's discuss important points about thyroid also now. Okay. Vascular surgery, trauma, and hernia. These are the 3 points I'll discuss directly in the T&D part itself. Okay, and some general points which are here and there. Now here we have to see beta thyroid gland which is there. We know thyroid gland is usually formed at the junction of anterior 2/3 and the posterior 1/3 of the tongue. And that site is known as foramen cecum beta. Yes, thyroid gland develops on the tongue at foramen cecum. After the development is completed, it descends down or it comes down into the neck via a thyroglossal tract. We know after the thyroid has descended down beta, it has come down, thyroglossal tract should disappear. But in some people, this thyroglossal tract does not disappear. It stays over there beta, and it leads to formation, it leads to collection of fluid inside it, causing a thyroglossal cyst. Now we know thyroglossal cyst will present to us in a childhood or in an adolescent patient with a midline neck swelling. And a classical feature of this is beta, this midline neck swelling usually moves with deglutition, that is with swallowing or protrusion of tongue. So whenever the patient swallows the food or when he moves the tongue beta, the swelling also moves along with it. Classical case of a thyroglossal cyst. Please tell me in the chat box which is the most common site of the thyroglossal cyst. Previous year question of your exam. Most common site for a thyroglossal cyst. Answer in the chat box. We know investigation of choice is ultrasound neck plus FNSE. Okay. FNSE just to rule out any cancer. So ultrasound neck plus FNSE is investigation of choice, and treatment is removal of the thyroglossal cyst plus the thyroglossal tract plus a part of hyoid bone beta. And this surgery is called as a cyst trunk surgery. Important question. So in treatment of choice for a thyroglossal cyst as well as a thyroglossal fistula is same, known as the cyst trunk surgery beta. No, it is not foramen cecum beta, it is subhyoid, below the hyoid bone. Do remember that the most common site of thyroglossal cyst is subhyoid or infrahyoid. I told you that is the most common site. Yes, most common site is subhyoid or infrahyoid. Now important is beta, if I talk about enlargement of the thyroid gland, we know enlargement of thyroid gland is known as goiter. Okay, most common cause of goiter is iodine deficiency beta. Okay, because we know that iodine is required for the production of T3 and T4 or your thyroid hormones. If iodine is deficient, there is less production of T3 and T4, causing hypothyroidism. And as there is hypothyroidism, there is more secretion of TSH by the pituitary, and that causes more stimulation of the thyroid gland, leading to its enlargement. Okay, so yaad rakhna, goiter can be seen due to hypothyroidism, like in iodine deficiency, or it can also be seen in hyperthyroidism due to Graves' disease. Yes, more commonly it is due to iodine deficiency or hypothyroidism beta, that has to be removed. And if there is a uniform enlargement of thyroid gland, that is called as a diffuse goiter. Okay, but when there is enlargement of the thyroid gland, when the inferior pole of the thyroid gland enlarges too much, that thyroid gland may enlarge into the chest or in the mediastinum of the patient, and that is classically called as retrosternal goiter. Because the thyroid enlarges behind the sternum, it is known as retrosternal goiter beta. If they ask you if it is a normal diffuse goiter, investigation of choice can just be an ultrasound. But if it is a retrosternal goiter, beta, investigation of choice has to be a CCT neck plus a thorax as well. Okay, because you have to investigate it properly. In retrosternal goiter, beta, ye chacha aayenge exam mein. What is this? Here you will ask your patient to elevate both the limbs above the head. And when my patient elevates both his arms above the head, beta, definitely my patient has redness, flushing or plethora on the face. This is called as which test? This is classically referred to as which test? Very good. Very good, beta. This is known as the Pemberton's test or the Pemberton sign. We know that Pemberton's test or the Pemberton signs comes out to be positive in a case of a retrosternal goiter, beta, only. Okay, no issues with this. Treatment, we know any kind of goiter always needs a surgical excision, beta, because it may cause pressure symptoms on the trachea, esophagus. That's the reason goiter always usually needs a surgical excision, beta. And most of the goiters can be excised by a surgical excision with the incision on the neck itself. Yes, a collar incision on the neck is enough. Only in primary retrosternal goiter, you may need to open up the sternum, called as sternotomy, beta. Now, thyroid tumors are of two types, beta, either benign or malignant. We know the most common benign thyroid tumor is a follicular adenoma. The most common benign thyroid tumor is a follicular adenoma, beta. But if they ask you about thyroid cancer or a thyroid malignancy, obviously the thyroid malignancy can be of two types. Either it is a primary thyroid malignancy or a secondary thyroid malignancy. Secondary thyroid malignancy means metastasis from some other cancer. Yes, the cancer has spread from somewhere else, beta, to the thyroid gland. That is called as secondary or metastasis. But primary thyroid malignancy or a primary thyroid malignant tumor is the one which starts arising from the thyroid gland. In thyroid gland, we have three types of cells. The cells which are present in the thyroid follicles are known as follicular cells, responsible for the production of T3 and T4. The cells present outside the follicles, known as parafollicular C cells, responsible for the production of calcitonin. And third are the first line of defense against infection, known as the lymphoid cells. So a primary thyroid malignancy may arise from any of these cells, beta. First, if the primary thyroid malignancy arises from the follicular cells, it can be of two types. Either it is differentiated or it is undifferentiated. Differentiated matlab biryani, undifferentiated matlab khichdi, right? So if it is a thyroid malignancy arising from follicular cells and it is differentiated in nature, it may either be a follicular thyroid cancer or a papillary thyroid cancer. But if it is a thyroid malignancy arising from the follicular cells and it is undifferentiated, undifferentiation is anaplasia itself, then it is a anaplastic thyroid cancer. If they ask you, beta, that if the cancer arises from the parafollicular C cells of thyroid gland, if the cancer arises from the parafollicular cells of the thyroid gland, it is known as a medullary thyroid cancer, beta. Please remember that it is known as a medullary thyroid cancer. And if the cancer arises from the lymphoid cell, it is a thyroid lymphoma. The cancer arises from the lymphoid cells, beta, it is a thyroid lymphoma. We know that lymphoma outside the lymph node always is a non-Hodgkin's lymphoma. Yes, outside lymph node, the lymphoma is always a non-Hodgkin's lymphoma, beta. Please remember that. And the most common type of non-Hodgkin's lymphoma in any other organ except the lymph nodes is DLBCL. Yes, most common type of non-Hodgkin's lymphoma in any other organ except the lymph nodes is DLBCL, diffuse large B-cell lymphoma. Okay? Whether you say stomach, whether you say thyroid, the most common type of lymphoma is DLBCL. Okay? Now, thyroid cancer staging, beta, it is similar to breast, somewhat different. T1 is cancer less than equal to 2 centimeters in size. T2 is more than 2 centimeters but less than equal to 4 centimeters in size. T3A means more than 4 centimeters in size. T3B means involvement of only the strap muscles or the ribbon muscles of the neck, that is hyoid muscles. Omohyoid, sternohyoid, thyrohyoid, all of these. And T4, involvement of any other structure, okay, apart from the strap muscle. So extra thyroidal extension, when the cancer spreads outside the thyroid and involves multiple structures. So please remember, you have to remember T3B, beta. Usually we know that when the cancer goes outside the thyroid, it is T4. But if it is only involving strap muscles, then it is T3B. Okay? If I talk about the most common type of thyroid cancer, beta, we know the most common type of thyroid cancer is the papillary thyroid cancer. Papillary thyroid cancer arises from the follicular cells and it is differentiated. So it is a very close differential of follicular thyroid cancer. So to differentiate between both of them, beta, you have to remember two things. One, that papillary thyroid cancer is more common in younger age group, that is 20 to 40 years of age. First thing. And second, it is associated with two important risk factors. One is a long-standing thyroglossal cyst, and second is radiation exposure in the past. So if they say young patient, radiation exposure or a cyst, it is more likely pointing towards papillary thyroid cancer, which is the most common thyroid cancer. And it is also the thyroid cancer with the best prognosis, beta. Okay, it is also the thyroid cancer with best prognosis. We know investigation of choice for a papillary thyroid cancer, it is ultrasound plus a FNSE. So ultrasound plus FNSE is investigation of choice. When I do a FNSE or when I send the mass for histopathological examination, beta, I'll be able to see this classical appearance, Sarkari image. We know the nucleus of these malignant cells appears empty, beta, just like the eyes of a cartoon known as Orphan Annie. Therefore, this is classically known as the Orphan Annie eye nuclei appearance. So Orphan Annie eye nuclei appearance along with this calcified lamellated bodies known as Samoma bodies. Orphan Annie eye nuclei appearance or Samoma bodies is a very classical feature of papillary thyroid cancer. Okay. We know treatment. Yaad rakhna, for all the thyroid cancers, the best treatment is total thyroidectomy, beta, removal of the thyroid gland completely. Along with, we can remove the level 6 lymph nodes known as central neck dissection. And if other lymph nodes are also involved, we have to go for a modified radical neck dissection. Yeah. In cases of papillary thyroid cancer, when the papillary thyroid cancer is hidden, beta, from there can be a lymph node metastasis in the patient, beta. So the patient is not having any thyroid swelling, but the patient rather comes to you with a lateral neck swelling, which is due to lymph node enlargement. And when you do a FNSE from that lymph node, you are able to see malignant thyroid cells. So please remember, this is called as lateral aberrant thyroid. So lateral aberrant thyroid is when there is a lymph node metastasis from a hidden or from an occult papillary thyroid carcinoma. So यहाँ पे तो कैंसर नहीं दिख रहा, but directly metastasis हो चुका है. That is a lateral aberrant thyroid, beta. Next important, if I talk about, here we have a second most common thyroid cancer. Please remember, second most common thyroid cancer is follicular thyroid cancer, beta, or it is also the most common thyroid cancer in iodine deficient areas. Yes. So please remember, overall most common thyroid cancer is papillary, but in iodine deficient areas, beta, like Africa for example, the most common thyroid cancer is follicular then. Okay? So second most common overall or most common in iodine deficient areas is follicular thyroid cancer. I told you two differences. Papillary was more common in younger patients. Follicular is more common in older patients, beta, more than 50 years of age. Second, papillary mein the risk factors were radiation exposure or a thyroglossal cyst. But in follicular thyroid cancer, the risk factor is a multinodular goiter, as you can see in the female. Multinodular goiter is an important risk factor for follicular thyroid cancer. Investigation of choice is the ultrasound with frozen section or a biopsy, beta. Yes, we know that ultrasound with a frozen section or a true cut biopsy, but not FNSE. Yes, FNSE is not diagnostic. FNSE can be done, but koi matlab nahi hai uska. So please remember, FNSE, that is your fine needle aspiration cytology, beta, is not a diagnostic of follicular thyroid cancer. Why? Because we know that FNSE cannot differentiate between a follicular adenoma, which is a benign tumor, and a follicular carcinoma, which is a malignancy. As it cannot tell you a difference between a benign and a malignant tumor, beta. That's the reason it is considered not diagnostic for a follicular thyroid cancer. Okay, so here we have to either go for a true cut biopsy or for a frozen section, but not FNSE. So FNSE is not useful in a follicular thyroid cancer. That has to be remembered. Now, whether it is a papillary thyroid cancer, follicular thyroid cancer, or an anaplastic thyroid cancer, beta, all of them arise from follicular cells, and therefore the tumor marker for all of them is serum thyroglobulin, beta. So the tumor marker for thyroid cancer is serum thyroglobulin, except in one type of thyroid cancer. And this type of thyroid cancer is known as medullary thyroid cancer, beta. We know medullary thyroid cancer is the one which arises from the parafollicular C cells. And as it arises from parafollicular C cells, beta, here the tumor marker is serum calcitonin. This was a PYQ. So serum calcitonin is the tumor marker of medullary thyroid cancer. We know medullary thyroid cancer is a neuroendocrine tumor, beta, and therefore it produces excess amount of serotonin, causing serotonin syndrome in the patient. Okay? So that is important. Next important, medullary thyroid cancer is also associated with red gene mutation, beta, chromosome number 10. And as it is associated with red gene mutation, it is a part of MEN2A and MEN2B syndrome. What is MEN? Multiple endocrine neoplasia. The MEN2A and MEN2B syndrome mein medullary thyroid cancer is seen, beta. We know in medullary thyroid cancer also the investigation of choice is ultrasound plus a biopsy, and then we go for a total thyroidectomy. And when I send a mass for histopathological examination, you're able to see this kind of a feature. A lot of malignant cells, and in between the stroma, you're able to see excess amount of amyloid beta. Yes. So amyloid rich stroma is there. What is the stain that is used for amyloid? What is the best stain used for amyloid beta? Why it is staining pink over here? Amorphous pinkish appearance is due to which stain over here for amyloid beta? Yes, it is A-cal type of amyloid which is deposited over here. But what is the stain? Congo red. Very good. Congo red stain is best one to be used for amyloid beta. Okay, shabash. Here a patient underwent total thyroidectomy beta and now presents with perioral paresthesia and carpopedal spasm. We know beta, perioral paresthesia means decreased sensation around the mouth and carpopedal spasm is this. Now, whether it is perioral paresthesias or carpopedal spasm beta, both of these are due to hypocalcemia, decreased calcium levels in blood. Why? So if a patient undergoes a total thyroidectomy surgery, what happens is a lot of times we know that there are 4 parathyroid glands on the posterior surface of the thyroid. So a lot of times during thyroid surgery, we may accidentally remove the parathyroid gland also. Or sometimes we may ligate this inferior thyroid artery away from the thyroid gland. And if you ligate the inferior thyroid artery away from the thyroid gland, it will not only cut off the blood supply of thyroid but even the parathyroid gland. That will cause devascularization of parathyroid gland. In both these conditions, whether you accidentally remove the parathyroid gland or you devascularize the parathyroid gland beta, in both the condition, the parathyroid gland may lose its function, causing parathyroid insufficiency. And due to parathyroid insufficiency, there is decreased amount of parathyroid hormone in the patient's body. And as parathyroid hormone is less, even the serum calcium levels of the patient decreases, causing hypocalcemia. Therefore, in hypocalcemia, the earliest symptom is perioral paresthesia, tingling or numbness. And these two clinical signs can be elicited called as Chvostek sign and the Trousseau sign. That is, when I inflate the BP cuff, my patient will have carpopedal spasm called as the Trousseau sign or the obstetrician's hands. Or when I tap along the facial nerve, my patient will make odd facial expressions or grimacing known as the Chvostek sign. Okay? So here the treatment has to be oral calcium or IV calcium gluconate with vitamin D3 beta, and along with that we have to give parathyroid gland implants. These parathyroid gland implants beta, they are commonly placed in the brachioradialis muscle. That has been a question. Reason, after every 6 years you have to replace them with new ones beta. That's the reason, because of ease of removal it should be placed over here in the brachioradialis muscle. The most common muscle used for the parathyroid gland implantation is the brachioradialis muscle. Okay? Here we have a question which says 75-year-old female presents with complaints of fever, generalized weakness, anterior neck swelling since 3 years, but it is rapidly progressing since the past 3 to 4 months. Pain is there over the swelling and hoarseness of voice. She gives history of weight loss but no history of cancer in the family. Most probable diagnosis is. We know beta, if the thyroid cancer is usually seen in 6th, 7th or 8th decade of life. So elderly patient. First. Second, rapidly progressive swelling which is also having pain. Usually thyroid cancers are painless, but if it is also having pain, if it is causing rapid involvement of a lot of structures beta, okay, or it is hard on palpation, is a classical diagnosis of anaplastic thyroid cancer beta. The anaplastic thyroid cancer is the least common or the rarest variety of thyroid cancer, and it will also have the worst prognosis among all the types of thyroid cancer beta. Okay, papillary is common in younger patients. Follicular may be common in elderly patient more than 50, but not very common in 70s and 80s beta. Okay, and definitely it is not very fast growing. It is not associated with any pain beta. Okay, medullary thyroid cancer, the patient may have other features like serotonin syndrome and everything, but here nothing of such was seen. And even medullary is not very common in 7th or 8th decade of life. The answer has to be anaplastic. Okay, so that was about surgery. The remaining topics, that is mainly your vascular surgery, hernia, and trauma, I'll try to integrate and take more questions of them in the test and discussion first thing. Second, even the general topics which are there somewhat here and there, also those which are important and have been asked, I'll try to cover those also in formats of questions in the test. Okay? The topics that we have discussed yesterday, I'll try to take lesser questions from these topics because we have done them once now. Okay? So the one where you can get trapped, those type of questions I'll include even from the topics that we have discussed yesterday, so you will get used to it. Okay? Hopefully this was fruitful and beneficial. So day after tomorrow we'll be having a surgery TND beta. I'll inform you the time. Basically, I'm not sure about whether it will be evening or morning. Most likely evening it would be. So get ready for that. Tomorrow you'll have anatomy test and discussion with me itself. It will start from 4:30 or maximum. 4:30 or 5 maximum. And yeah, anatomy test and discussion. The tests I'll send them. They will upload it on the app. and tomorrow we'll start the discussion in the evening.